are joining from rest part of the world. Today we have got three guest speakers. The first one would be Dr. Gopinathan from Kolkata, Dr. Ranjit Varghese from Pune, and Dr. Ramesh Balasubramanian from Madurai. Let me introduce our first guest speaker for the day. We have with us Dr. Gopinathan M from Chennai, and he's going to lecture us on mantle cell lymphoma, navigating through biological heterogeneity and management in 2025. Our second guest speaker is Lieutenant Colonel Dr. Ranjit M. Varghese from Pune, and he's going to lecture us on non-fragmented approach to fragmentation hemolysis, case-based approach. And our third guest speaker is Dr. Ramesh Balasubramanian from Madurai, and he's going to lecture us on bispecifics regimen improves survival in large B-cell lymphoma. This webinar, as usual, is brought to you by Mumbai Hematology Group, supported by Roche, Natco Oncology, Unipath, Lucien, and Nirvin Life Sciences, and very well managed by Perfect Square. I thank Dr. Apurva Verma and Team Roche, Lucien, Unipath, Nirvin, and Natco, Mr. Yash, Mr. Kalpesh, and the team from Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest for the day, Dr. Anup Tosniwal from Aurangabad, our three guest speakers, Dr. Gopinathan, Dr. Ranjit Varghese, and Dr. Ramesh. All our discussions were themselves very eminent hematologists as well as hemato-oncologists, and you participants for sparing your Sunday morning, afternoon, or evening from whichever part of the world you're logged in. Let me give you a flavor of our next weekend activities. Next Saturday, that is 30th of August 2025 from 7 p.m. Indian Standard Time, your Dr. Devdutt Basu from Pondicherry speaking to us on myelofibrosis causes and effect. And the following day, that is Sunday, 31st of August 2025 from 11:30 a.m. Indian Standard Time, we have Dr. Satish Kumar A from Bangalore speaking to us on an update on ADC and bispecific based treatment of lymphomas from ICML and EHA 2025. Let me introduce our discussions for the day, and they are here displayed in alphabetical order. I will pause for a while for you to have a look on all our discussions for the day. These are very eminent hematologists, hemato-oncologists, medical oncologists, all across the country. So with this, let me introduce our special guest and chief guest for the day. We have with us Dr. Anup Tosniwal from Aurangabad. Dr. Anup Tosniwal is consultant medical oncologist and hemato-oncologist, director and founder of Shri V Care Clinic, Chhatrapati Sambhaji Nagar, Maharashtra. He did his MBBS from Government Medical College, Aurangabad, followed by MD in Internal Medicine from Kasura Medical College, Bangalore, followed by DM in Medical Oncology from very prestigious Tata Memorial Hospital, Mumbai. He subsequently cleared the European Society of Medical Oncology examination and was awarded fellowship for clinical research from Australian Clinical Oncology Research Society. He is also an executive committee member, Western Zone, Indian Society of Medical and Pediatric Oncology. He is also the reviewer for Indian Medical and Pediatric Oncology Journal, South Asia Oncology Journal, and Curious Journal of Medical Science. He is the Associate Professor of Medical Oncology in Government Cancer Hospital, Chhatrapati Sambhaji Nagar. He has more than 10 international research papers and publications, and is the first qualified DM in medical oncology in Marathwada and Central Maharashtra. It's my privilege to welcome Dr. Anup Tosniwal to inaugurate our webinar and give some words of wisdom. Well, thank you so much. I stop over here. Over to you, Dr. Anup.
Thank you, sir. Thank for that kind introduction. And good morning, everyone. It gives me immense pleasure to join today for this important academic seminar under the aegis of MHG. First of all, I congratulate organizers and MB Agarwal sir and Kurana sir for bringing together such a rich academic program for highly relevant topics. We are constantly witnessing rapid advance while navigating biological heterogeneity in mantle cell lymphoma. Also, there are a lot of complex mechanism in hemolysis, and also we are here to learn about adopting the novel therapies like glofitamab in large B cell lymphoma. And I hope this discussion These discussions are not only academically stimulating but also directly impact the way we care for our patients. I believe platforms like this create a bridge between knowledge, collaboration, and clinical practice. And the real beneficiary of such deliberations are our patients who place their trust in us and better outcomes and quality of life. I look forward to hearing from our distinguished speakers today, and I'm confident that this seminar will inspire new ideas, collaboration, and most importantly, better patient care. With this, I formally inaugurate today's session and wish it to be a great success. And thank you. And I think without wasting time, we should proceed to our guest lectures. Thank you, sir.
Thank you, Dr. Anup, for the prestigious words and very well crafted speech. Thank you so much for accepting our invitation as our chief guest for the day. Thanks a lot. Let me share the screen again. So now it's time to introduce our first guest speaker for the day. We have with us no other than Dr. Gopinathan from Chennai. He has been our regular panelist, discussions every time in all the MG webinars. Very active academician. It's my formal duty to introduce Dr. Gopinathan to all of you. He is a consultant hematologist and BMT physician at MGM Healthcare, Chennai. He did his MBBS from Government Chengalpattu Medical College, Tamil Nadu. MD in Pediatrics from JIPMET Pondicherry. Senior Resident in Pediatric and Medical Oncology at JIPMA, followed by DM in Clinical Hematology training from SGPGI, Lucknow. As a research project, he standardized LCMS technique for monitoring therapeutic levels of methotrexate during high-dose methotrexate infusion in childhood ALL. His clinical interest includes bone marrow failure syndromes, thalassemias, HLH, acute leukemias, bone marrow transplant, as well as cellular therapies. His publications are in infantile cholestasis, HLH, AML induction toxicities, as well as gastrointestinal manifestation in hematolymphoid malignancies. He has been the gold medalist in undergraduation and secured the first in DM hematology examinations. He also initiated the bone marrow transplant services at MGM Healthcare and Cancer Institute. It's my privilege to welcome Dr. Gopinathan, and he's going to lecture us on mantle cell lymphoma, navigating through biological heterogeneity and management in 2025. Well, thank you so much. I stop over here. Over to you, Dr. Gopinathan.
Thank you, sir, for that warm introduction. And at the outset, I would like to thank Professor M.B. Agarwal for keeping us academically active and encouraging all young hematologists like us to be very academically active and providing a constant learning material to all of us. So with this, I'd like to share my screen. I hope it's visible and...
Not yet. Yeah, now it's visible. Full screen mode, please. Yeah, perfect. Okay.
Yeah, sure. So thanks for this topic. So I did choose to speak on mantle cell lymphoma because I felt it's one of the least prevalent lymphomas that we commonly clinical across. So every time we do commonly come across DLBCLs, but mantle cells not much is talking about. And I thought because with the evolving literature of its biological heterogeneity, how will management is going to change in 2025? So that's the rationale behind choosing this topic. So, and I'd like to lecture on the following headings. We'll have a short introduction. We'll just understand the disease epidemiological pattern in our country and how pathology and molecular pathogenesis has advanced per se with regards to mantle cell lymphoma, and how do we risk stratify in the current era, and how has the frontline management unfolded between the fit patients and unfit patients in current era. A short take on relapsed MCL, and because cellular therapy is coming way forward in our country, so what's the role of cellular therapy for mantle cell lymphoma, and how do we move ahead with regards to management of mantle cell lymphoma? So we all know that it is a very rare type of BNHL, contributes to about 4 to 6% of entire BNHL basket, and the incidence is roughly quoted to about 1 in 2 lakh population. And this is very notorious to involve, to have a male preponderance, and particularly elderly males, or the main cohort of patients where you commonly see this subgroup of lymphomas. And it becomes a challenge over there because you really can't do intensive chemotherapy over there, and you have to tailor chemotherapy and immunotherapy to a certain extent that will make the patient, tolerate the therapy as well. And once upon a time, pre-rituximab era, this was considered to be a very aggressive malignancy and with dismal prognosis. But now, once after the advent of rituximab and with a lot of small molecules coming in the market, it has got very good overall survival post-rituximab era and the small molecule era. So we all have realized that there is a lot of heterogeneity in mantle cell lymphoma per se, where it is contributed not only by the cells but also by the tumor microenvironment. And how is MRT going to change the management, and what are the new agents, and cellular therapy is going to make a lot of revolution in the management of mantle cell lymphoma. So I was just ever wondering when I was just reading to the first few introduction chapters of this particular topic. Usually it says it's a disease of elderly males. So the research publication came much earlier, like in the early 2000s, where it said, most of these males as like our aging process, where we have chip seekers and all this coming up, with aging, you also have loss of Y chromosome that is considered like an more of an age-related clonal event. It is also considered like an age-related attrition event. And this Y chromosome is actually protective. It does, kind of, it doesn't have, it is the only chromosome which doesn't have oncogenes. So when elderly males, when they lose, this Y chromosome, probably it may be contributing to lymphomagenesis. So that was one of the earliest theories that was put forward. And this paper came in Hematologica in the early 2000s, and that keeps interesting. And there are a lot of things to do with gender and mantle cell lymphoma in particular, not only from this loss of Y chromosome, you also have this SOX11, which again belongs to sex determining Y region in males, and you see the difference in outcomes between males and females, which I'll be alluding in the future slides. So coming to what is happening in our country, this is as early as early 2000, the first decade of 2000. This was a publication from Mumbai where you can see almost 2,773 cases of BNHLs are analyzed, and you can see mantle cell lymphoma contributing to almost 3.4%. So that is roughly fits in our basket also between 2 to 6%. And you can see the earliest analysis, progression-free survival analysis. The results weren't much impressive, because you can see that it is not very much impressive. You can see as low as the PFS as low as at 1 year and 2 year being 51% and 27%, with the overall survival of 78 and 72%. I hope the survival is much better in the current era. And again, this is one recent publication talking about the spectrum of lymphomas in India, which again roughly says that mantle cell lymphoma constitutes about 3.86% of the total BNHL basket. So it becomes important that, since it's so rare, the treatment patterns that is followed across the country may be varied. The way that the patient presenting to you may be varied. So it's important that, all hematologists like us should put forward how differently are we managing these patients, what are the various clinical evolution patterns that we are managing. And if you can kind of summarize and put a data together across the country, it would be more beneficial to the forthcoming generation. So and again, what are the various predisposing factors that was taught in the evolution of mantle cell lymphoma? Probably if somebody is having a very early age onset of mantle cell lymphoma, I did tell about that it's a disease of elderly. If somebody is having a very early onset MSL, you need to think of mismatch repair defect, which is much talked about in the solid tumors. To a certain extent, pesticide exposure, IL-10 polymorphism, and certain autoimmune diseases, they can contribute to the pathogenetic evolution of mantle cell lymphoma. And a lot of theory and research is under the exploration, where you have certain microRNA patterns and epigenetic alterations that are being studied in the evolution of mantle cell lymphoma. So with this, we just directly go on to the disease. So as any neoplasm has a precursor state, so Mrs. Mantle cell lymphoma has also got a precursor state, which is very rightly called as in situ mantle cell neoplasia. And this you can see very much in some of the surgical specimens that you resect. Say, for example, if you resect a gallbladder for some other reason, for a GB stone, you can actually find some of, this in situ mantle cell neoplastic patterns. The only thing, or if you remove tonsil for some other reason, you can find, these kind of in situ mantle cell neoplastic patterns. The only thing is, you will actually find an expansion of the mantle zone here, but the lymph node architecture is reasonably preserved. You see the fatty hilum reasonably preserved over there, and there is no germinal center obliteration here. So that is how we differentiate it from the actual mantle cell lymphoma that we commonly treat. And again, this mantle cell, in situ mantle cell lymphoma, can also coexist with other lymphomas. Say, for example, a patient who is actually suffering from follicular lymphoma can have some in situ, mantle cell neoplasia. That shouldn't confuse our clinical picture. Very rarely you can have blood spillovers in this in situ mantle cell neoplasia also. You may have a patient with blood spillover of mantle cells plus in situ mantle cell neoplasia also, but the treatment management is not going to change. It is kind of put under the category of basket, which is managed like wait and watch. Coming to the proper histopathology of mantle cell lymphoma, you see here there is clear-cut expansion of mantle zones with kind of obliteration of the germinal center, and this is the typical cyclin 1D1 expression, which is the pathognomonic feature of mantle cell lymphoma. So we all say that the typical phenotype is CD5, 20, 19 surface IgM or IgD, and FMC7 with either monoclonal kappa or lambda, but the CD3 should be dim or negative, and it should have a strong cyclin D1 expression. So that is a typical immunophenotype that is expressed by mantle cell lymphoma, and we all know that once upon a time it was talked in multiple cellular patterns were talked: small cell pattern, nodular pattern, pleomorphic pattern, blastoid pattern. But now what is more even importantly talked about is Ka67 is an important prognostic indicator rather than morphology. So that what is the current understanding of our literature. And coming to the pathogenesis, we all know that after the in situ mantle cell lymphoid neoplasia stage, you have two varieties, or you have broadly two baskets of mantle cell lymphoma. One is the leukemic non-nodal variant, which is actually germinal center experienced and antigen exposed. Okay, so this mantle cell lymphoma particularly has a hypermutated IGHV sequence status, and it is usually SOX11B negative. And this usually behaves indolent, and it has got a very good prognosis. But eventually, over the age of over the years and over the ages, they can slowly acquire clonal abnormalities and can become aggressive. Whereas the other category that is talked about is your unmutated IGHV pattern plus SOX11 mutation containing mantle cell lymphoma, which predominantly behaves in a non-leukemic and nodal pattern, which is a classic mantle cell lymphoma, and this is slightly aggressive, and this behaves bad slightly than your non-nodal leukemic pattern. And again, over the years, this will have a very shorter progression interval, and they can rapidly acquire clonal abnormalities because they have a lot of genomic instability to form a blastoid MCL. So, and again, what is the main driver? As I was telling you, it is the cyclin D1 expression that we see commonly in the expression of this lymphomas. So, cyclin D1 is the main driver. So, it is the major checkpoint between G1S. So once this is altered, you have a continuous proliferation going on. So that forms the major pathogenesis behind this lymphomas. And again, as a clinician, it is very important to know that you may have discrepancy between your IHC and your FISH pattern. So the common FISH that we use is a break apart probe, where we see at this point of time we do two FISH. We do translocation 1114 as well as 17P is must for diagnosis of all mantle cell lymphoma. So sometimes if you have an IHC pattern, but if you have a FISH negative, that is a typical break apart fusion probe that is negative, you need to suspect that there can be a cryptic translocation. Sometimes there can be a variant translocation. The partners of IGH can be different. It can be a kappa or a lambda light chain. Sometimes you may get IHC negative but FISH positivity, where you need to think that the cyclin D1 ultimately is a protein. So if you have a different isoform of protein, there can be an IHC negativity. Sometimes if you have mutations in the C-terminal domain of this cyclin D, then you may have an IHC negativity. Very rarely you may get both IHC negativity and FISH negativity, but your molecular aberrations, everything can, in morphology, everything can fit on your flow pattern, everything can fit in your mantle cell lymphoma, where you need to suspect, apart from cyclin D1, there can be cyclin D2, cyclin D3, or cyclin E rearrangement. And again, talking very importantly about the SOX11, as I told, again, this has got this SOX stands for sex determining Y region. The S stands for sex determining Y region. And SOX11 is basically it's a transcription factor that basically helps with the fetal neurogenesis. So if this gets mutated, then it can actually promote lymphomagenesis and mantle cell lymphoma by constitutively activating this PAX5, where it drives differentiation of B cells to plasma cells. It has got a very strong augmentation on BCR signaling, and it prevents the germinal center transit of mantle cells. It just tries to retain within there, and it also promotes angiogenesis and cell adhesion, that we all know that that is the main important risk factor for any tumor proliferation. As well as it kind of creates an immunosuppressive microenvironment over there with a lot of CD70 expression, increased Treg infiltration, and down modulation of antigen processing and T cell activation. And the SOX11 is not, confined to mantle cell lymphoma particularly. You can also see some group of Burkitt's lymphoma and lymphoblastic lymphomas do express SOX11 in their genomic signature. So when so much like this is what we had differently talked about in the last 3-4 slides, but when so much is talked about cyclin D1 and SOX11, it is increasingly recognized not only that you have a lot of epigenetic aberrations contributing to mantle cell lymphoma, and chromothripsis and TP53 alterations and an unstable genome contributes to pathogenesis of mantle cell lymphoma, as well as now it's so much is talked upon tumor metabolomics. So this is not only contributes to the tumor formation as well as tumor resistance. So one of the important pathway that is talked about is the oxidative phosphorylation pathway that in the electron transport chain. And not only in that, in the BCR signaling pathway, not only BTK and NF-kappa B, you have multiple downstream pathways like PAT, AKT, mTOR, and that's why various targeted agents are coming against the treatment of mantle cell lymphoma. So you can have mutations over there. And apart from that, you can have various gain of function mutations. You have Notch1, Notch2, and multiple other aberrations that can happen in the pathogenesis of mantle cell lymphoma. And in the current era, we are studying multiple DNA methylation patterns, and which can actually determine this germinal center experienced and germinal center inexperienced mantle cell lymphomas, of which if somebody is germinal center experienced, it usually kind of behaves subtle, and this has got a slightly better prognosis than your germinal center inexperienced mantle cell lymphomas. So putting all the data together, now that we have a different, genomic cluster of mantle cell lymphomas, which are labeled as cluster 4, cluster 3, cluster 2, cluster 1, and the prognosis goes from the most worst to the most better prognosis. So if you have CCD and cyclin D1 and ATM, it slightly has got a better prognosis, whereas if you got this SP140, TP53, and NSD2 mutations, that usually come under your bad profiling, bad genomic profiling of your mantle cell lymphoma. So having said that, having studied about the basic pathology, molecular pathogenesis, what do you do when you actually have a patient of mantle cell lymphoma? As a clinician, you will obviously determine the performance status, you will see the age, you will see the other comorbidities, and you will see the extent of involvement. So most of the time, if you have a disseminated blood pattern, you can simply diagnose it by a flow cytometry, because sometimes the morphology in a blood pattern may be confusing. You may be actually confusing it with an acute leukemia, because many a times this disparity happens between our pathologists also. Many times we have a clinical diagnosis of acute leukemia, but when later we run the flow and clinically re-examine, then it actually turns out to be a leukemic variant of mantle cell lymphoma. And it also commonly confuses with other indolent lymphomas like CLL, right? CLL and all other indolent follicular leukemic spillover. So you can actually get confused over there, and where your IHC is going to help. Suppose if you have a typical lymph nodal pattern where your typical IHC and FISH is going to help. So in these days, we do flow cytometry, immunophenotype, FISH testing, particularly for 11, 14, and TP53, as I already told, and MXC rearrangement in some, in some patients. But what is upcoming really is your genomic assessment also. And nowadays, with a lot of literature available, we can see a disparity between TP53 by FISH and TP53 by genomic sequencing. And a lot is coming about the prognosis and how you tailor management of mantle cell lymphomas. So having said that, diseases always don't read textbook. This is what our teacher used to tell. You can have typical atypical mantle cell lymphoma pattern where you need to really correlate your clinical pattern of the disease and then with your lab phenotypic features. So having said that, you are diagnosed now, obviously you need to stage and risk score the disease. One is to prognosticate your patient and how well intensive you are going to treat the disease. So the age-tested algorithm is your MIPA scoring, which takes into consideration of your age, performance status, LDH, and WBC counts, of which you can put it into low, intermediate, and high, and you can see the survival curves differing, very much over there. And you have, apart from MIPA, you have these two things. There is MIPA B and MIPA C. So which takes into account K67. If you use it as a continuous variable, it becomes MAPAB, that is MAPA biological index. And if we use as a dichotomous variable, like more than 30 and less than 30, it becomes MAPA-C. And this clearly dictates your outcome and how bad they are going to behave. So putting it all together, what a clinician needs to know apart from this MAPA staging, is that enough? So you also, nowadays, there is a lot of data coming up on the PET, depending upon the baseline metabolic tumor baseline tumor load and your metabolic tumor volume. And we know that apart from the gene mutation that I was typically describing, like TP53, SOX11, ATM1, Notch1, Notch2, KMT2D, CD, CND, NK2A, and MYC, you also have many complex karyotypes. That's why nowadays they are advocating to do routine karyotypes also. If you have a complex karyotypes, they will invariably do bad. And of this, the only ATM mutation does really well, because you can also see that it is a mutation that is commonly seen with CLL. So only this particular mutation does reasonably fair, but compared to all the other genomic abnormalities, which really do bad. And now you have the driver, that is your genome, but you also need to have a smooth microenvironment. Say, for example, there's a driver sitting in the car here. Though he drives well, you need to have a good vehicle, you need to have a good road as well. So the tumor microenvironment also is very important, because if you have a very immunosuppressed environment, that actually the tumor gains a lot of growth potential and it can become aggressive. So what is recently known about this tumor microenvironment? You have various type of cells that infiltrate the tumor microenvironment. Say, for example, this FOXP3, CD163 positive macrophages, and the PDL1 expression. So if you have a much immunosuppressive environment, as also dictated by higher CD4, CD8 ratios in an ALC, AMC ratio, that is your absolute lymphocyte and absolute monocyte ratio, and to a certain extent microbiome is recently talked of. So if you have a very immunosuppressive microenvironment, then your disease can actually become more aggressive, and not only that, cytokines also. So putting all that in the pathological aspect, we also have host-related factors. Though we exactly subclassify them, we exactly sequence them, we put into personalized medicine, but it is the host who is going to tolerate the therapy. So with increasing age, you may have bad survival. With increased comorbidities, yes, you're not going to do well. And achievement of CR, how well they are going to respond. Yeah, MRD is come in almost each and everything of hematology now. So MRD negativity, particularly once after the induction regimen, how is it going to? That is going to impact your long-term outcome. And early relapse, that is so-called POD24, is an important clinical determinant of how the patients are going to do in the long-term era. So having said that, as a clinician, you need to identify patients which you're really going to treat upfront and which you're going to really wait and watch. So first, obviously, for any clinician, as much as you don't touch the patient, it's much better. So in mantle cell lymphoma, as I said, it's a heterogeneous basket. You have various intolerant behavioral patterns to the most aggressive patterns of lymphoma being expressed. So we have a certain category of mantle cell lymphomas where you can actually wait and watch, and this is one of the earliest papers published about the wait and watch series in mantle cell lymphoma, of which talks about if you can see the commonest predictors of where you can wait and watch, and if the patient has a good performance status, lower stage mantle cell lymphoma, lower IPA score, or if it is a leukemic pattern, there you can actually do a wait and watch, right? Because ultimately, once if you're going to start the treatment, you are going to expose them to chemotoxicities, because once upon a time only intensive chemotherapeutic regimens were available, right? So the better category is the leukemic presentation, which is your SOX11 negative or hypermutated IGHV pattern. So this particular subgroup of lymphomas you can actually wait. And if the patient has not got any B symptoms, lesser extranodal involvement, low LDH, non-aggressive morphology, because most of these earlier papers, that time this genomic signature fish and nothing was available, so they did classify predominantly based on their morphology, which talked like pleomorphic and blastoid pattern is not the pattern where you need to actually wait and watch, and that's what was followed. So as I said, once upon a time only intensive chemotherapy was available. So in order to basically avoid this treatment related toxicities, they did keep and wait and watch, and they did find a better overall survival with the observation group. And they did find this age and gender difference as well. As well as if you see, most of those who are elderly, they're kept on wait and watch. And again, females tend to have a lot of wait and watch policy. This is probably maybe the behavior of lymphomas with respect to the gender. Males actually behave bad than females, and a lot of females are put into wait and watch, and they did reasonably well in the observation cohort. And sometimes, the ancient practice was just to do a leukapheresis when the WBC touches more than 50,000, and then you can continue keeping these patients on wait and watch. But now there is a lot of learning about precursor states and a lot of treatment or interference with the precursor states itself. So this is one of the earliest papers that looked about treating a smoldering MCL, or the so-called indolent MCL. This was conducted by the Geltama group, where it recruited more patients more than 18 years. 50 patients, roughly 50 patients, and the 4 to 6 patients were available for data presentation at that point of time. And it predominantly included leukemic non-nodal groups and very indolent groups like lymph node only up to 3 centimeter and non-blastoid morphology, and with preferably Ki-67 30%, less than 30%. So this was the only inclusion criteria over there. They didn't do gene sequencing at that point of time. But later on, based from the biological repository, they also did analyze based on the TP53 mutation status also. So what did they do is they did give 8 doses of rituximab at 375 milligram per meter square, and they did 2 cycles of continuous ibrutinib, at 560 milligrams. That was the dose that was given. And if the patient has sustained MRD at 2 years to the power of 10 to the power of -9, they were discontinued ibrutinib. So, and you can see the graph is almost flat, it almost flats, and you can never see a evolution there. But here also, if you can see, this TP53 group did have an earlier progression, even in this group, within 2 years of when they are off therapy, they did progress, and some did progress on therapy as well. And again, classical mantle cell lymphoma did, the non did slightly bad. So the overall treatment response in this year were roughly about 86% and 84% in this particular group of smoldering lymphomas. So now we actually go to the full-blown treatment of mantle cell lymphoma, particularly in front, first from a frontline treatment. So as a clinician, what do you need to do? You need to optimize your chemoimmunotherapy backbone. You need to consider whether you can actually do some targeted agents, and you need to define the role of your autologous stem cell transplant and how well you can keep your therapy MRD guided, and improve the maintenance therapy so as to achieve the so-called long-term survival with mantle cell lymphoma. So this was one of the earliest papers from MD Anderson group, which actually was doing hyper-CVAD and high-dose methotrexate to those relapsed lymphomas. In those days, the historical controls were actually the R-CHOP. So this is the comparison over there at that point of time. You can see the R-CHOP people did very bad, but when they did those intensified therapies, they slightly had a better survival. Obviously, it did have a slightly lot of treatment toxicities, which kind of refined over the years, but probably it is a single center experience, and over there maybe most of the patients are very fit and they did tolerate well, and that's why this regimen holds good for center like MDAC. So this was one of the long-term experience published by MD Anderson Cancer Center in the recent, somewhere in the 2015 to 2016, with this median follow-up of 13.4 years of this those patients who had received hyper-CVAD there, of which even now 1/3 of them are in remission, and the median failure-free survival and overall survival are almost 4.8 years and 10.7 years, which is not really bad, and the failure-free survival really plateaued after a period of 10 years with a 15-year failure-free survival of 30%. So probably if you choose the young fit patient whose biology is also good, they may reasonably do well, and those who have attained an early remission. So this talks about the importance of doing MRD even in mantle cell lymphomas. If they have CR, achieve CR after 2 cycles of hyper-CVAD, their failure-free survival drastically increased from 4.8 years to 8.8 years. And those who didn't achieve CR after 2 cycles, they received a maximum up to 8 cycles of hyper-CVAD. But obviously there was some degree of survival difference between the earlier response attainment group. And the 10-year cumulative incidence of AML or MDS is almost 6.2%. So that is quite concerning maybe. But it is almost equal to any other dose-intensive treatment group. So while that was simultaneously going on, our Nordic, the second Nordic mantle cell lymphoma group published, this cytarabine-based induction does really better. So it is not so as intensive as hyper-CVAD. This is slightly better tolerated, and this included 116 patients, and this was also a long-term data of almost 11 years, of which at the end of 11 years, even 40% of are in CR norm. So which is kind of really good. So these were all of the intensive chemotherapy regimens that was practiced in mantle cell lymphoma upfront. The Nordic trial, the Hermin et al. And Lima's paper, which most of them employ the RDAP induction, and once after the induction therapy, they go on to autologous stem cell transplant as a consolidation strategy, where between these conditioning regimens per se, they can either use a beam or the so-called B conditioning, that is your carmestin. And there was a debate at that point of time between TBA-based conditioning and beam versus B conditioning, but it kind of didn't make a real difference over there. And if you see, the Nordic and Lima group used maintenance strategies, and Nordic group used rituximab only if they are MRD positive. So in those days, it used ASO PCR, of translocation 1114 as an important maintenance strategy. Whereas this Lima trial, despite, without any kind of MRD, they did incorporate rituximab maintenance every 2 months for 3 years. And you can see and kind of quite an impressive PFS of almost PFS of 8.5 years with the Nordic group. And here, even with Lima also, you can see a 4-year PFS of 83%. And same as with the Hermine et al., where you can see a median treatment-free survival of 8.4 years. So and again, now that you do an intensive chemotherapy and then you do an autologous stem cell transplant, whether that was actually needed. So that was the next question that people had. So one of the earliest trials that did compare whether that did contemplate and did think whether ASCT is actually needed. I would say ASCT was compared to interferon alpha, which ultimately I would not say it is a very good comparison or a healthy comparison. I would say obviously ASCT arm did better, but this question of so-called ASCT is actually needed is kind of challenged with the recent papers and recent trials which are incorporating this small molecule agent. So the EPIC study is your triangle study, which again did involve your fit patients less than 65 years. I'm sorry for the correction here. It's less than 65 years, stage 2 to 4 lymphomas with a very good performance status, and those who are fit for high dose cytarabine and ASCT consolidation. It did randomize them into 1:1:1, 3 arms, where arm A did give R-CHOP alternating with RDAP for 6 cycles, followed by an autologous stem cell transplant. And then initially maintenance was not as a part of this trial, but then later, since they did prove the importance of maintenance, they did add maintenance later on. And again, apart from arm A, you have arm B, which talked about autologous transplant and ibrutinib. And the third arm, luckily, if you see, that doesn't have autologous transplant at all. It only has ibrutinib. So you're actually comparing between chemotherapy alone, chemotherapy plus ibrutinib, and ibrutinib alone. But you'll be surprised to see that actually the autologous arm did kind of inferior to this arm which incorporated autologous plus ibrutinib. And if you see, compare among the 3 arms, those that employed autologous stem cell transplant, even with ibrutinib, it didn't make a much difference. That means autologous transplant didn't add much value when you add small molecule agents like ibrutinib, right? Ultimately, but when we are not exposing them to the small molecules, that is like ibrutinib at all, these people did really bad. So whether you add ibrutinib to autologous transplant or not, so the autologous transplant really doesn't make much difference when you had small molecule agents like ibrutinib. So that was the basic conclusion of this study. Obviously, you need to have wait out and watch for the long-term data over there. So now that was studied, questioned about autologous transplant, then whether we really need to do such an intensive chemotherapy, for this kind of patients, and considering the cumulative incidence of toxicities and these kind of secondary malignancies, whether we really need to do such an intensive chemotherapy was talked about in the window 1 trial. So which did give a non-chemotherapy backbone, that is your rituximab ibrutinib induction. They did almost up to 12 cycles, and if they achieve complete response or a partial response, they did have 4 cycles of hyper severe, and which kind of continued up to 8 cycles if the response was not adequate. But if they are progressive disease, kind of they are not taken off, they are taken off during the study. And if you'll be interested to see that after this 12 cycles of ibrutinib rituximab itself, which is so-called part A. Part A is a non-chemotherapy arm, and part B is your chemotherapy arm. So this is part B, and this is non-chemotherapy arm is part A. So the overall response rate was close to 98%, and CR was 87%. And you can see that at most at the end of 5 months, most of the patients did achieve a CR. So, it almost took 5 months to achieve CR in those patients who had actually achieved that. And the median PFS and OS are not reached. And this particular group, the TP53 group, high Ka and blastoid subgroup did bad even with this regimen. They did bad, and which told them that it need to do kind of a ibrutinib rituximab maintenance. So it was initially not planned, but it was later added. So this trial was further refined, where they did classify the patients into low risk, intermediate risk, and high risk based upon this Ki, tumor lymph node size, low MIPA scores, and some of the morphological features of high risk disease. So what they again did is they did 4 cycles of IR, but from the 4th cycle, they did they did add venetoclax, the ibrutinib rituximab. From the fifth cycle, they did add ibrutinib rituximab and venetoclax. That once after the part A is complete, which is total of 12 cycles, this low risk people didn't receive any chemotherapy at all. Okay, and this intermediate risk people did receive 2 cycles of hyper CVAD, whereas the high risk people received 4 cycles of hyper CVAD. And kind of the graphs are almost similar between, and they were put on IRV maintenance, that is ibrutinib, rituximab, and venetoclax maintenance for 2 years. And, still the median PFS and OS is not reached, and the impressive data is almost, these groups were doing almost well till 2 years. 2 years, there was not major difference, except in the later part of 5 years, there was some dip with the high risk subset. So that was what this, trial or window two trial did teach us. So now what we did understand from all the above previous treatment upfront trials is those with the TP53 mutations are indirectly not going to do well. So that's why they kind of devised an upfront intensive regimen with this newer molecules, which is your zanubrutinib, obinutuzumab, and venetoclax. And they did kind of do a combination of this based on 160 milligram BD of zanubrutinib, obinutuzumab, 1 gram, on cycle day 1, 8, 15, and day 1 of cycles 2 to 8. And after 2 cycles, venetoclax was added in in a ramp up schedule. And you can see the overall response was 96%, and with a CR rate of 88%, which is quite impressive in this particular group. Obviously, this trial is in the early phase. We have a lot of data to come up in the forthcoming years. Now that we have talked about the fit patients, management of mantle cell lymphoma in fit patients, the elderly group, this is the major group that most of us are going to see. They are not going to be very fit, or they're going to carry a lot of comorbidity burden. So for this, how we are going to manage? So the initial trials, which is your LIM 3002 study design, which looked at R-CHOP versus VR cap, where addition of bortezomib did make a better difference. And again, among all the various regimens available for treatment of elderly mantle cell lymphomas, starting from maybe R-CHOP versus RFC, BR versus R-CHOP, BR versus R-CHOP, or RCVP, you can find a slightly better response with the BR. So that is what most of us are doing in these kind of elderly lymphomas who are not fit. And there was one trial which did try to look at, addition of ibrutinib to BR versus BR, and they kind of had a reasonably good progression-free survival. So that is what we need to take at the end of the day, whereas bortezomib to BR didn't make much difference, whereas ibrutinib adding to BR did have a better PFS survival for this subset of patients. So talking about so-called response assessment in mantle cell lymphoma, still now we may be doing imaging guided response assessment for all of our mantle cell lymphoma patients. But most of these trials used a combination of these tests to do MRD. Apart from the imaging, they also did employ flow cytometry. Once upon a time, it was only consensus, it was only ASO PCR that was used to test lymphomas. But now we have this clonosec, clonosec coming up a long way in management of mantle cell lymphomas. So, and again, the newer techniques, which is this CAP-seq and phage-seq, they can also keep a track of your resistant clones as well. So this was some of the advances with regards to MRD monitoring in mantle cell lymphoma. So it can dictate you about needing a maintenance or not. It can define the finite therapy. Suppose, for example, if you're going to deal with an indolent mantle cell lymphoma, and if you're going to act them in an early stage, you can actually define the finite therapy. It can redefine the role of autologous transplant. Maybe in future, it can actually dictate you whether you need to consult a particular patient with a CAR T cell therapy. So, however, we need to be very much optimistic for that. And again, maintenance rituximab. So this was a multiple trials that talked about adding maintenance rituximab, or some trials did also talk about maintenance lenalidomide. On the recent trials, if you see, they all employ ibrutinib, venetoclax also as a part of maintenance. So the only takeaway message from this particular slide is only with BR induction. If you do a BR induction, actually addition of maintenance rituximab didn't make much difference in the survival. Whereas compared to all the other intensive chemotherapy arms, your maintenance rituximab did achieve some kind of benefit. So now switching gears slightly to the management of relapsed refractory mantle cell lymphomas. Obviously, when we talk about relapsed refractory disease in NA B cell lymphomas, you have this 4 agents coming into play, of which pirtobrutinib, these kind of BTK inhibitors are come up much away in the management of relapsed refractory mantle cell lymphomas. You have this bispecific antibodies, you have ADCs, and you have this CAR T cell therapies that are employed for the management of mantle cell lymphoma. Having said that, what are you going to do when they relapse? right? Obviously, they'll be much more older, they'll be much more, unfit at the time when they relapse. So again, wait and watch is not a bad option if they are really asymptomatic and indolent. Whereas if they become symptomatic and progressive, and I could not say, because most of us, of you and me here, are not able to access ibrutinib at this point of time. So we can maybe keep BTKI naive and BTKI pre-treated. So if you have BTKI naive, then you can actually go in for BTKI plus venetoclax, or you can go in for immunochemotherapy, or if at all still if you're not responding to that, then you can go for these kind of CAR T cell therapies and other small molecules. Whereas if they are already BTKI pre-exposed, maybe in our case, if they're ibrutinib pre-exposed, then CAR T cell is an option. The other non-covalent BTK inhibitors like pirtobrutinib is an option. Suppose if it is a late relapse, you can also have an option of re-challenging the BTK which your future used, which used earlier in the prior lines, as well as venetoclax comes along much way in the management of this relapsed lymphoma. So nowadays, I don't think ibrutinib is easily accessible, and most of us have stopped almost using it. But then the only thing to take away from this is ibrutinib was once used rampantly in the management of mantle cell lymphomas, and you can see this is the cumulative analysis of those patients, almost 370 pooled patients data, which said ibrutinib did achieve a reasonable PFS of almost 12.4 months, particularly if they are used upfront at the point of relapse. They did much better compared to the ones who are already exposed to multiple lines of chemotherapy. Now, moving on slightly to acalabrutinib, you know that, compared to ibrutinib, acalabrutinib is lesser, has got lesser off-target side effects, and this did reasonably achieve a median PFS of 22 months and an overall survival of close to 5 years as well. And now, coming on to zanubrutinib also did fare in this, badly treated patients, and they did reasonably achieve an overall response rate of 83.7%, and they did give a reasonable PFS of 33 months and overall 3-year OS of 74%. So having said that, we are not going to use that alone in the coming eras. We are going to use that in multiple combinations, maybe with bortezomib, maybe with lenalidomide, maybe with venetoclax. And these were the initial trial data that were available. And when you combine these two agents, obviously you can see a better response rates. So this is very important trial that need to be talked about, which is the use of ibrutinib and venetoclax in relapsed refractory mantle cell lymphomas, and they did fare well than your single agent ibrutinib. This is your simpatico trial, and you also have this Oasis cohort B, which employed ibrutinib, obinutuzumab, and venetoclax in relapsed refractory mantle cell lymphomas, whereas the cohort C is actually treatment naive. The cohort A is only use of ibrutinib and obinutuzumab and not involving venetoclax. So in this Oasis trial, whatever we analyzed is the cohort B. You have cohort A, which employed only ibrutinib and obinutuzumab, and cohort C is treatment naive. So compared to cohort A, cohort B did much better. So when you use a combination of three agents, people do much better. That's what the take home away from this particular slide. Having said that, we all know that, BTK, covalent BTKs, like ibrutinib, acalabrutinib, zanubrutinib can attain resistance, after a period of continuous use. And the mutation that is commonly talked about is your C481 mutation, which is the commonest mutation that from the knowledge from the CLL, we all know that that point mutation actually confers ibrutinib resistance. But the important thing to take away from here is in mantle cell lymphomas, it is not the point mutation that causes your resistance. There are multiple subcellular pathway mutations that can actually implicate resistance, with regards to mantle cell lymphoma management. So we have the newer non-covalent binding agents like pirtobrutinib, becabrutinib, fenebrutinib, and nemtabrutinib made available. So that can actually make difference in this subset of patients, and of which we have again multiple trials evaluating the response in mantle cell lymphoma. The one is Bruin trial, which talks about pirtobrutinib, which has an reasonably overall response of 56.7%. You can find this number slightly lesser than the previous trials that used ibrutinib, acalabrutinib, zanubrutinib, but you can actually find this pirtobrutinib slightly lesser. The reason here is, these group of patients were actually prior BTK exposed. They were already exposed to either ibrutinib, acalabrutinib, or zanubrutinib. That's why, though it's a non-covalent BTK inhibitor and it's a new kid on the block, this subset of patients actually did slightly lesser, because they are the heavily pretreated patients. And obviously we have the cellular therapy. right? So now that the last part of the talk is the cellular therapy, and this is the talk of the town these days. So we must also remember that autologous stem cell transplant and allogenic transplant is also a cellular therapy, and now we have this newer CAR T cell therapy that is coming up even in the management of mantle cell lymphomas. So we all know that from the old experience, it has got a very good data with regards to DLBCL and ALL per se, and to a certain extent maybe follicular lymphomas, but the other data over the mantle cell lymphoma is actually really sparse. So you can see this is how the recent this is a recent paper in Nature which talked about European perspective and American perspective with regards to application of cellular therapy in the management of mantle cell lymphoma. You can again see here which are the subset of patients you can actually choose in for CAR T cell therapy. So compared to autologous and allogenic transplant, where really age and comorbidity matters, CAR T cell therapy you can actually choose some kind of these unfit patients as well. And the NRM risk, non-relapse mortality risk is slightly lesser, and the second neoplasm risk is a kind of almost close to autologous transplant that we can say, but lesser than the allogenic transplant. And the efficacy, yes, in refractory and high-risk disease, it has got a much better efficacy than your autologous transplant and allogenic transplant, as we all know. And the curative potential, yes, we are subject to long-term data, and costs are really skyrocket high. And now we are in that gray zone where we don't know what to tell to the patients and what we need to talk to the patients. And maybe with coming years, when the data builds up quite strong, we'll be pretty strong in our counseling. So this is what this cellular therapy talks about. How do you employ cellular therapy? I said, even autologous transplant is important, is an important first line cellular therapy. It's a form of cellular therapy. So if how do you employ them as a first line agent? So if it is a standard risk mantle cell lymphoma and BTK available, then the European perspective puts, European perspective again puts no autologous transplant over you doing an autologous transplant. Whereas if it is BTK not available, then kind of need to form an autologous transplant angle. Whereas if it is in high risk mantle cell lymphomas, it treat on a conventional CAR T if it is available, and then put on arm A plus I. And high risk MCL BTK not available for first line therapy, then you need to again put on CAR T trial or triangle arm A, that is your autologous transplant arm. Considering your second line, use of second line use of cellular therapy in second line treatment of mantle cell lymphomas, you can actually consider autologous transplant if you do a salvage. And these are the various cohorts, BTK naive, autologous transplant naive, BTK naive, autologous exposed. Then you can actually do a BTK without cellular consolidation if they are already done autologous stem cell transplants. BTK naive plus high risk futures, then you need to consider CAR T. So the overall take-home message is, the CAR T cell therapy is slowly coming up, slowly evolving up in the management of mantle cell lymphoma. So these were the two agents that were available. One is your Brexucell and Lizocell. The only takeaway from point from this is both this cohort included heavily pre-treated patients, more than 2 lines of treatment up, plus there would be chemoimmunotherapy plus BTK exposed. This Brexucell has slightly gotten higher incidence of neurotoxicity compared to your Lizocell, whereas the infection rate in neurotoxicity as well as infections, whereas the NRM is slightly higher over the Lizocell arm, maybe due to the cohort patient selection. And again, if you see the overall response rate and CR rate, you can see that Brexucell slightly did better than your Lizocell arm. And again, allogenic stem cell transplant is really not a bad option to consider. The one thing is many people may not be able to access the CAR T cell therapy, or that maybe not been available as a part of clinical trial. Again, your patients are going to be old, so the standard of induction, the standard of conditioning here with regards to allogenic transplant in mantle cell lymphoma is usually a rig conditioning. And you can see, this is a pool data available from various group, ABMT and all those things. And you can actually choose either a match-related donor, unrelated donor, or a haplo, a very less representation of cord blood group over there. And this also did achieve a reasonable PFS of 76% at 1 year and overall survival of 86% at 2 years. So it's not really a bad option to consider if you are having this is the ready-made access that everyone in the world is can do. And bispecifics, yes, not so much rampant data like your DLBCL, but it did all the bispecific trials employed a certain subset of patients to this mantle cell lymphoma, relapsed mantle cell lymphoma patients. So that's why the data is also sketchy there. You can see glofitamab, a reasonable CR rate of 73%, but the response is only short-lived. Epcoritamab is just only 50%. Odronextamab, the CR rate is only 33%. Mosunetuzumab is overall, when it is used as a single agent, the response are not really great. But when they use polatuzumab and mosunetuzumab, it did reasonably pick up, to a close of ORR of 75% and 73% over there. And again, CNS disease in mantle cell lymphoma per se is not very common, but it can come with high-risk disease during the time of relapse. The use of high-dose methotrexate is controversial at that point of time, not much of benefit, but you can actually employ high-IT intrathecal methotrexate. Radiation is often tried, and you need to use a higher dose of ibrutinib over there, almost to a dose of 840 milligram. But zanubrutinib, which is a newer agent, has got a very good CNS penetrating action. The median survival, however, remains very, very dismal. So now that you may land up, having all these agents available, you may land up with a patient who is BTK exposed, BCL2 exposed, CAR-T exposed, and these are so-called triple class refractory, like how we say in myelomas, they're so-called triple class refractory mantle cell lymphomas, and they have got really, really bad survival. But what do we do for these kind of patients? You may have ROR1 antibody drug conjugate, which is targeting a different antigen, that is ROR1 antigen. So the agent is zilovertamab, and you actually have BTK degraders. There's a novel agents in action, the so-called PROTACs, and novel BCL2 antagonist, sorry. So that is your sonrotoclax and all these things. And bispecifics, again, they can be an option when you are already exposed to these three agents, and you can see multiple other newer agents, including BTKR, HCK inhibitor, SYK inhibitor, anti-TIGIT antibody. So this is an important thing that can determine your immunosuppressiveness of your tumor microenvironment. So all these can kind of modulate, and kind of can make a sudden difference. And improvisation of CARs per se, you can have a triple tri-specific antibody targeting CAR. So they can be used as an option for these kind of triple class refractory patients. And I would conclude by saying that there is a lot of space to explore. Chemo-free approach is a reasonable target to avoid toxicities. And we need to use precision medicine to stage and sequence therapy, and we need to improvise a lot on consolidation and maintenance strategy based on understanding a lot of tumor resistance mechanisms with our basic scientists. We need to improvise treatment with regards to modulating our tumor microenvironment, and a lot of collaborative work is needed in the country, because these are all very, very less common lymphomas. Mantle cell lymphomas, not everybody gets to see, or if they get to see, they get to see in few numbers. You can see the representation overall is only 3 to 4%. A lot of collaborative work has to go on so that the management is uniform, and we do a much better work to our patients. So with this, I end my talk, and thanks for the opportunity.
Thank you, Dr. Gopinathan. Wonderful talk. Fantastic to listen to you. And now I request all our discussants to please put the hand raise signs so that you can start a question session with Dr. Gopinathan. So before the hand raise signs keep on pouring, Dr. Gopinathan, in your clinical practice, how do you treat blastoid variant of mantle cell lymphoma as of now?
Blastoid variant of mantle cell lymphoma. So first is if they are better to go in for a small molecule agent for these kind of patients. So basically, rituximab, acalabrutinib, venetoclax based regimen would be the better choice to induct these patients, and then subsequently a kind of this window triangle two strategy is what reasonably that can be followed with this blastoid variant of mantle cell lymphomas in the current era.
So for young fit patient, would you like to take this goal in your life that in 2025 that will absolute for not to go for transplant in mantle cell lymphoma by any means?
Yeah, young fit patients, I would still go for autologous because these are time-tested therapies. We have still a lot of data. So young fit patients, I would definitely kind of consider autologous stem cell transplant, but older patients, maybe not.
So based on the triangle study, still you want not differ from this autologous stem cell transplant now?
It's very kind of the data is just evolving up. So the long-term data, I would still, I mean, they did have that window one did demonstrate a long-term data, but for high-risk patients, even over there, they did use a lot of cycles of hypersevere methotrexate to those patients. They did went up to 8 cycles. So I don't know how much of our patients are going to tolerate that by that many number of cycles of hypersevere. Practically, I have not come across such a bad situation now till now. But I don't know how much are they going to kind of tolerate such 8 cycles of hypersevere. So maybe for in that angle, consideration of autologous would be a better option. So that would be slightly safer strategy to do.
Thank you. And the third question from me is that in this era of the novel agent, you take it ibrutinib, acalabrutinib, venetoclax for mantle cell lymphomas. Any subgroup of subset of patients where you will go for chemo-based approach?
Okay. Subgroup of patients. So obviously, young, fit patients with a not very bad genomic segregation. If they're not TP53 mutated, if their K is not sky high, or they're not got very bad mutations, then these are the subset of patients where we can actually consider chemoimmunotherapy. So at this point of time, we routinely do flow and fish, but of late we have started employing using NGS also. From the FFPE tissues, I have started using sending NGS as well, and kind of that can we can tailor therapy to that. So based on that, I'm taking some decisions of late. So luckily, I'm not getting a young fit patient of mantle cell lymphoma. All the mantle cell lymphoma that I'm treating are more than 60, 65. So I'm not able to try much.
Anything about allogeneic stem cell transplant mantle cell lymphoma?
Yeah, allogeneic. So that's what I was telling, sir. If they are not exposed, if they are not affordable to CAR T at this point of time, if there is a CAR T trial available employing mantle cell, that's a reasonable way to refer them. But if they are not accessible to CAR T, RIC allo transplant is not a bad option to do if they relapse after an allogenic transplant. Maybe the patient should be fit at that point of doing an allogenic stem cell transplant. So that all the cohort of patients that I had shown in my slides are based on the European registries. Maybe their fitness levels are much different from the type of patients that we see. So they also did almost 1/3 to half of them used only a RIG-based conditioning in their patients. So that is something that we need to keep in consideration. So the TRM can be as high as 30% at the end of 1 year. So, and particularly elderly patients, obviously we may not, we may choose elderly donors from their own brothers and siblings. There's an increased chronic GVHD risk. Maybe if you need to choose a son or daughter as a donor, then they might be haplos. So haplos may be quite challenging and risky to do in our subset of patients.
And the last question is, what is the treatment or algorithm? Is it different for those patients who are cyclin D1 negative mantle cell lymphoma?
Not though the data is very, very, the subset of patients that you actually get cyclin D1 negative maybe less than 10%, the management algorithm doesn't change. But you have to take into account the morphology, the other genomic markers, so that with that you can go in for the same treatment approach.
Perfect. So, Dr. Gopinathan, thank you so much. Fantastic lecture. Any discussion, want to ask any question to Dr. Gopinathan before we go for the second talk? Well, anybody?
Gopinath?
Yes,
Yes,
Dr.
sir.
Please go ahead.
Yeah, wonderful lecture. I just want to have that NGS will pick up all the mutations, SOX11 or cyclin D1, or it is cell surface expressed NGS.
Sir, recently the typical mutation that we have a set of 20-25 genes, sir. So they are picking up all Notch, SOX11 and all they are picking up. Whatever you are asking the target area of interest, Notch, SOX11, BCL2, SF140, NSD2, D2, they're all picking up.
Including cyclin D1.
Including cyclin D1. Cyclin D1 I haven't come across, but it should be CCN D1, the original genome, it should be able to pick up.
So if that is being done, probably that even if the ISC negative, flow negative, or anything,
can pick up.
this can be recovered.
Yes.
Okay. And so you feel that it is a mandatory to do the NGS?
It is not
Sort of.
mandatory, I would say. The fish and flow and IHC is mandatory. But the dual apart fish NGS is not mandatory. But I think in the current era we should do NGS because we will refine our
Okay.
therapies much better. Maybe
Thank
they may be
thank you so much.
accessible to CAR T, so we may that would help us.
Thank you. Thank you.
I have one query, Dr. Ramaswamy, sir. You said the cyclin D1 only positive and the flow negative and IHC also negative. But only
Yeah, but sometimes will it pick up by the NGS
because if cyclin
because
D1
he was
is positive in many other conditions also, according to me, I
yeah.
think. Yeah.
No, but the corroborative morphological evidence as well as other fish evidence and other things. Suppose ISC flow both are negative. So in that case, if you are picking up the cyclin D1 with the in relation to the morphology, probably whether we are dealing with that
Then
overlapping picture or
maybe the typical IHC pattern if you don't get. Yeah.
Thank
There is one question from the audience from Dr. Kannan. How do you look for MRD in mantle cell lymphoma? And is it the marrow specimen, or if the marrow is not involved, what do you do for minimal residual disease?
So at this point of time, so this is an important question that when I was reading, I was also exploring. So most of the trials that used only ASO PCR, but I discussed with one of the hematopathologist also. So ASO PCR is not recommended now. It's only the clonoSEX, like how we do our ALL MRD. If at all it's a marrow involved disease, you can actually do a clonoSEX, serial follow-up of clonoSEX. You need to determine the baseline IgHV, the typical pattern of the changes that was present in the earlier sample. Based on that, you can do a clonosec, and the circulating tumor cell from basically from the peripheral blood is what they are doing.
Thank you.
So the same context, sorry, in the same context, suppose the bone marrow is non-involved, the original tissue biopsy specimen, can it be used for the exploration of the clono sequence?
It can be used. So I recently had a patient. So I did they're very kind of too much knowledge people. So they were asking for this MRD, they were asking for this CAR T. So initially I didn't give a bone marrow sample to them, but I had a block of the lymph node tissue of the patient. So I did determine IGHV sequence there, and now that I can track the MRD, from the current sample. So that is what I'm planning to do.
Thank you.
Thank you, sir. Anybody else, any question? We'll go with the second talk then. Fine. So fine, Dr. Gopinathan, thank you so much. Fantastic, lovely talk, lovely discussion. Now we'll go with the second. Let me share the screen again. So our second guest lecture is by our second guest speaker, Lieutenant Colonel Dr. Ranjit Varghese from Pune, and he's a clinical hematologist at Command Hospital, Pune. Let me introduce him very well to all of you. He did his MD in Internal Medicine from AFMC Pune. This was followed by DM in clinical hematology from AIMS Delhi. Following are the list of his recent awards achieved by him: API All India Medicine Quiz, Epicon Hyderabad 2016 first prize, Annual Hematology Quiz by Delhi Hematology Group 2022 first prize, Best Kept Case Report ISHBT Northwest Chapter PJ Chandigarh 2022 first prize. His areas of interest include bone marrow transplant, myeloproliferative neoplasms, and hyperinflammatory syndromes. Today, he is going to lecture us on non-fragmented approach to fragmentation hemolysis, a case-based approach. Well, thank you so much. I stop over here. Over to you, Dr. Ranjit Varghese. Has he joined?
Sir, for the second speaker, the time is 11:30.
Oh, is it so? Oh,
Yeah.
it's 11:10.
Yes.
So we can just have a break then.
Yes, sir.
Anybody else should want to discuss anything, open to all with Dr. Gopinathan. There is one question, Dr. Gopinathan. It has come in the chat box. Dr. Gopinath, are you there? Yeah, Dr. Gopinath, are you there? Mr. Kalpesh or Mr. Nikhil,
Yes, sir.
we can take a break, I think, for
Okay.
20
Okay,
minutes.
sir. Yep.
Sure.
So we can start.
Yeah. Thank you. So let's move for our second guest speaker for the day. We have with us Lieutenant Colonel Dr. Ranjit M. Varghese from Pune. And let me introduce him once again to all of you. He's a clinical hematologist at Command Hospital, Pune. He did his MD in internal medicine from AFMC, Pune. This was then followed by DM in clinical hematology from AIMS, New Delhi. Following are the list of his recent awards achieved by him. I will name for you: API All India Medicine Quiz, Epicon Hyderabad 2016 first prize, Annual Hematology Quiz by Delhi Hematology Group 2022 first prize, Best Case Report ISHBT Northwest Chapter PJ Chandigarh 2022 again the first prize. His areas of interest include bone marrow transplant, myeloproliferative neoplasms, and hyperinflammatory syndromes. And today is with us and is going to lecture us on non-fragmented approach to fragmentation hemolysis, case-based approach. I stop over here. Over to you, Dr. Ranjit.
Good morning, everyone, and greetings of the day to our worldwide viewers. At the outset, I would like to thank Professor Agarwal and the Mumbai Hematology Group for the kind invite for giving me a lecture to the audience. So, is my screen visible, sir?
Yes. No, not yet.
Okay. So, is it visible now?
Yes, now it's visible. Can you make it in full screen mode?
Yeah, okay. So, I'd be talking about TMA spectrum disorders. Basically, what we are trying to cover in this lecture is we would be going through a case-based approach to the TMA spectrum disorders. And this is the outline of my talk. We will go through introduction, bit of pathophysiology, labs, case-based approach, and none of the above, that are the mimickers, and the controversial topic, that is platelet transfusions and TMAs. So at the outset, I would like to say that I work in a public sector hospital, and we don't have any access to the complement-based therapy. So we would be restricting our talk, or I would be restricting our talk to clinical experience which I have been exposed to. So without wasting much time, I would start my presentation. So thrombotic microangiopathies, the hallmark is mechanical hemolytic anemia and thrombocytopenia. Along with that, microvascular thrombosis as a sequelae to the thrombocytopenia and mechanical hemolytic anemia, leading to end organ dysfunction. The presentations are dramatic and often life-threatening. They are medical emergencies which need to be intervened quid pro quo. And etiology can range from congenital to acquired. So first and foremost thing, we will define mechanical hemolytic anemia or microangiopathic hemolytic anemia. So it is always smaller than the intact RBCs. Is my screen visible?
Yes, it's visible. Please go ahead.
Okay.
We are able to hear you and see your screen also. Yeah.
I am not able to see my screen. It's gone off. Can I just stop sharing for a second?
Yes, no issues.
Is it visible now?
Yes, now it's visible, but make it in full screen mode.
Okay.
Yeah.
So they lack central pallor and can have irregular triangular shapes and pointed projections. The most important thing to note here is microspherocytes, they have to be counted as schistocytes equivalents. They are smaller than the usual conventional RBCs, and there is lack of central pallor. So these are the schistocytes which are seen in circulation. Here we can see various bizarre helmet type cells, triangular cells, schistocytes, all of them we can see over here. Along with that, this is the higher magnification view where we can see a helmet shaped cell like this with irregular projections. And this is the a cartoon which is showing schistocytes for a better visualization and understanding for our viewers. So the other important cell which is considered as schistocyte equivalent is a microspherocyte. So the red one which is circled over here, that's a microspherocyte, and it is being counted as a schistocyte equivalent, and the total count of schistocytes is based on combination of both schistocytes as well as microspherocytes. So the cause of schistocytosis in peripheral blood is hematological as well as non-hematological. The hematological can be due to microangiopathic hemolytic anemia, megaloblastic anemia, and myelofibrosis. Non-hematological being hypertensive emergencies, disseminated intravascular coagulation, malignancies, autoimmune disorders, solid organ transplant complications, or hematopoietic stem cell transplant complication, prosthetic heart valves, thermal burns, and HELLP syndrome. So what are the golden rules? We need to count minimum of 1000 RBCs, and the schistocyte count should be above 1% in adults to be significant. And if a smear is prepared, it should be less than 3 hours if the sample is kept at room temperature, and less than 8 hours if it is refrigerated at 4 degrees centigrade. So the cutoffs, again, if there is a clinical suspicion of TMA, is the TMA a prominent feature on peripheral smear? You should count minimum of 1000 RBCs, and the cutoffs being for less, not likely a TMA is less than 1%, or premature infants it is less than 5%, and in adults it is more than 1% and more than 5%. So absence of schistocytes doesn't say that it is not a thrombotic microangiopathy. We need to daily examine if there is strong clinical suspicion for TMA, or if none, we need to explore alternative diagnosis by assessing the smear. So coming to the pathophysiology, the central to the pathophysiology is ADAMTS13. ADAMTS is a disintegrin and metalloproteinase with thrombospondin 13 motifs which are type 1. So it is synthesized in the hepatic stellate cells, and the ADAMTS13 is central figure. It cuts the large von Willebrand multiples into smaller ones. So the resting ADAMTS13 conformation is closed. Whenever we have a deficiency of ADAMTS13, either through inhibitory antibodies or pathogenic variants which lead to congenitally low ADAMTS13 levels, the ADAMTS13 level is low. It is not able to cut the ultra large von Willebrand multimers, and thereby there is large multimers, ultra large multimers in circulation, particularly in the microcirculation, which increases the shear stress and opens up the ADAMTS13 conformation, where the cryptic hidden sites are exposed, and there is hyperadhesiveness of von Willebrand factor, leading to excess platelet binding in the microcirculation, particularly in the arterioles and the capillaries, leading to thrombus formation and downward cascade events. Coming to the pathophysiology of complement-mediated HUS, here we have 3 pathways, that is classical, lectin, and alternative. The classical pathway is involved in removal of the immune complexes and apoptotic debris removal. Lectin pathway get activates on exposure to carbohydrate, particularly on the microbial surfaces. And alternative pathway, it is a peculiar pathway that it has got a tick over mechanism. That means it keeps on spontaneous hydrolysis, and the pathway generates 1 to 2% of complements every hourly. So it is a delicate balance between the activators and the regulators. So in complement-mediated HUS, there is a loss of function of mutation of complement regulators, or maybe autoantibodies against FH, or gain of function mutations, particularly towards the complement activators. So if there is a alternative pathway involvement, that leads to amplification of the immune responses, leading to launch of membrane attack complex, that is the terminal complement cascade gets activated, and there is endothelial injury secondary to cell lysis. Coming to the diagnostics, so we have 3 tests. Mainly we use 2 tests in clinical practice, that is activity levels and the antibodies. Antigen levels, they have to be interpreted with caution, because it may be normal in TTP due to the presence of immune complexes, or reduced due to accelerated clearances. So always the antigen levels should be interpreted along with activity levels. So measurement of ADAMTS13, it is based on direct or indirect detection of the cleavage products of the von Willebrand factor, and it is expressed as a percentage in a normal pooled plasma, and the calibration should be against the new WHO international standard ADAMTS13 plasma. So direct methods, we have the SDS page, the SDS agar gel electrophoresis, the FRETS assay, and the indirect methods, the collagen binding assay, the ristocytin aggregation assays, and the functional ELISA assay, which is the most commonly available particularly the clear ones are available in the commercial labs. So pre-analytical variables we need to address or look at is use of citrated plasma is strict, and it should be centrifuged to eliminate platelets, and EDTA plasma should be avoided because EDTA is an irreversible inhibitor of ADAMTS13, and it would lead to spuriously low levels. So if the testing is delayed or delay is contemplated, particularly if we don't have resources or in-town testing or in-hospital testing, the sample should be stored at -40 degrees to prevent proteolysis. So coming to antibodies, again, which are commonly seen in acquired thrombotic thrombocytopenic purpura or immune TTP, the most common antibodies are IgG type, IgG4 more than IgG1, followed by IgA and IgM, and these are directed against the spacer domain. Non-inhibitory antibodies can also be detected, leading to accelerated clearance. The clinical implication is sometimes the patients may have a negative antibody test because of the non-inhibitory antibody, and there is a higher mortality rate, particularly with ADAMTS13 levels, which are lowest in the quartiles. And the key takeaways are less than 10, that gives us the diagnosis to be a TTP, and you need to consider alternative diagnosis if the levels are more than 20, and the plasma exchange generally is rendered ineffective if the levels are more than 20. And particularly in immune TTP, we need to regularly monitor the low ADAMTS13 levels during clinical remission raises relapse and progression risk, which needs to be closely monitored. So we anticipate a turnaround time of 4 to 5 days for our labs to arrive. So there are few bedside clinical tools which are used for preventing delay in initiation of therapy, because it is a medical emergency and any delay in therapy would lead to a mortality rate which is over more than 90%. So there are two scores which are commonly used on the bedside. That is, one is a French score where you have the platelet count and the creatinine. If you have two, that is the diagnostic sensitivity of predicting ADAMTS13 deficiency is around 98.8%, and the plasmic score, which we commonly use on the bedside, the components are P is for platelet count of less than 30,000, hemolysis, that is reticulocytosis of more than 2.5%, undetectable haptoglobin, and indirect predominant hyperbil. There should not be any active solid malignancy, active cancer, or any past history of solid organ or hematopoietic stem cell transplant. The MCV should be less than 90, and the creatinine should be less than 2. So the score, if it is low, the frequency of severe ADAMTS deficiency is extremely low, that is between 0 to 4%. And if you have a high score, the probability goes up and it becomes 62 to 82%, based on which we need to start the therapy, that is plasma exchange. So coming to the first case, so here we have a 39-year-old female, which is a recent case. So she was admitted in an outside hospital with symptomatic anemia and jaundice of 1 week duration. Fever and diarrhea was the background illness almost 3 weeks back, and she was referred from a private hospital to us in view of no improvement post B12 infusions. Admitted for evaluation of bicytopenia. On the same evening, was found missing from the ward. She was found in the left corridor in an altered state. Urgent CT head, SDH involving the right temporoparietal region, bilateral frontal regions without any midline shift. She was shifted to ICU in view of low platelet count along with IC bleed, and hematology services were involved. Here we calculate the plasmic score as we had discussed earlier. She was having hemolysis, however the schistocytes were less than 1%, and coagulograph was normal. The Coombs tests were negative, high LDH with normal renal functions. Again, because of the high plasmic score, we had taken the samples for ADAMTS13, and autoimmune and APS workup was also sent, since she being a young female. And she was started on Plex. So there was a diagnostic dilemma that whether it is bleed is predominant or this thing. Since the plasmic score was high, we started the patient on Plex, and the fresh frozen plasma was used as a replacement fluid. Along with that, anti-edema measures were used. So post 2 sessions of Plex, again GCS hovering between 9 to 11 and labile hemodynamics. So we added methyl prednisolone to the already existing Plex, and the plasma volume was increased to 1.5 times of exchange. There was no change in platelet count or hemolysis related parameters, and post 5 sessions of Plex and steroids, there was no improvement in the sensorium. There was no change in labs. There was intermittent agitation, and rituximab was started, and she was having labile hemodynamics, and Plex was started with the pressor support. Here we got labs back. She had undetectable ADAMTS antibody activity levels, and antibodies were very high. The ANA was 3+ by IF, and ENA profile was suggestive of U1 RNPY positivity. Hypocomplementemia, both C3 and C4 levels were low, and troponin were very high. So post 9 sessions of plaques, hemoglobin somewhat stabilized, platelets improved. However, she developed psychosis. We exactly don't know whether it was ICU psychosis or defervescence, and she achieved defervescence. Post 2 sessions of rituximab and 13 sessions of plaques, there was significant improvement. There was platelets of more than 1.2 lakhs and schistocytes were less than 1%, and LDH normalized. However, on 24th of June, in a dramatic turn of events, within 30 minutes, the patient developed seizures, dysautonomia, severe metabolic acidosis. She was intubated and she crashed. We exactly don't know what was the cause of death, and that was query disease or a venous thromboembolism or a myocardial infarction. So coming to the definition and prevalence, it is a primary thrombotic microangiopathy, generally associated with very severe ADAMTS13 deficiency. And most commonly, we have inhibitory autoantibodies, particularly against the spacer region, and female sex is considered a risk factor. Then coming to the demographics, less than 9 years of age in children, immune TTPs are rare. And in adults, it is 30-fold increase, and particularly females are predisposed to having an immune-mediated TTP. However, in pregnancy, particularly the first pregnancy, hereditary TTP is a consideration. So coming to the pathophysiology, autoantibodies either neutralize or increase the clearance, and the severe ADAMTS antibody deficiency leads to ultra-large von Willebrand multimers which are in circulation, leading to microvascular thrombosis, thereby mechanical hemolytic anemia and end organ damage. So the known factors are here. We have severe ADAMTS deficiency, as in our case, predisposing factor being a female gender, and precipitating factor, probably an infection which she had contracted 3 weeks back, would have led to this episode. So coming to the clinical features, we do not wait for the complete pentad to appear. In large cohorts also, it is less than 10% of the patients have complete pentad. And MAHA with thrombocytopenia without any alternative explanation, please consider the diagnosis of TTP and the plex has to be initiated. And you can have varying amount of presentation, neurological system involved, non-specific symptoms, pain, abdomen, you name them, that is there. We need to have a high clinical suspicion, and generally the patients present as in a very dramatic fashion or in an explosive manner. So coming back to the clinical features, again, the key central figure are MAHA and T, that is thrombocytopenia. Neurological abnormalities can vary from severe to minor. That is, minor is confusion and headache. Severe can be coma, stroke, or seizures. As in our case, she was having seizures with altered sensorium continuously. Acute kidney failure is described in 5% of cases, but most importantly, it is altered kidney functions without failure is documented in approximately 50% of cases, and fever as a manifestation can be seen in 10% of cases. So the suspicion less than 10%. Again, it is DTP. Then we did anti-ADAMTS antibodies, again positive. That becomes the diagnosis was to be finally described as autoimmune TTP. Supposedly, if the test is negative, we need to monitor it continuously. And if it at least positive one time, then it becomes autoimmune TTP. However, when the ADAMTS13 is always detectable and it is always negative, the antibodies are negative. So we have a TTP which is of unknown mechanism and always less than 10% the activity levels and negative. That means it can be either an inherited TTP if there is mutation, and no mutation, we don't have an etiology. So the goals of therapy is, first and foremost, is to induce a clinical response. The cornerstones are PEX and the immunosuppressive therapy that would lead to normalization of platelet counts, and prevention of exacerbation has to be prevented because in approximately 30 to 40% of cases, we have exacerbations. The key figures, again, we have discussed therapeutic plasma exchange and immunomodulation, steroids and rituximab as the first line agents. And we will not withhold plex for patients who are suspected to have clinical suspicion of thrombotic microangiopathy and particularly TTP. So the exchange is about 1 to 1.5 times the plasma exchange. And in critically ill patients, the plasma volume is approximately detected to be around 40 ml per kg, which is calculated by the Nadler's formula. So it has to be repeated until there is recovery or until TTP is ruled out or another diagnosis comes in. And the other important thing is always use fresh frozen plasma as the replacement fluid. Many of the times the treatment is rendered ineffective because sometimes albumin is mixed along with plasma 50-50. So you may wonder why your patient is not responding. So always use plasma. So it replaces the ADAMTS13. and it removes the autoantibodies and ultra-large von Willebrand factor which are in circulation. So what are the adjunctive therapies? The adjunctive therapies is steroid. There is a head-to-head comparison with cyclosporin A, so which says that prednisolone has a superior suppression of the anti-13 antibodies and improvement in the ADAMTS13 activity. It is highly cost effective, particularly in our subcontinent, and there is moderate reduction in mortality in critical cases. So even the ISTH guideline also recommend as addition to the first line therapeutic plasma exchange rather than doing a plasma exchange alone. Second is for management of immune TTPs, rituximab. It should be started in all patients who are having less than 10% activity. There are many dosing regimes described. The most optimal dosing is 375 mg per meter square weekly for 4 weeks. The timing, dose it either prior to a plasma exchange and resume the plex after 24 to 36 hours of plasma exchange. And it has got lower relapse rate. If you use rituximab upfront, then the relapse rates are approximately 11% as compared to 50% in when it is compared with placebo, and there is definite mortality benefit. Even the ISTH guideline says that addition of rituximab to corticosteroids and TPE than to corticosteroids and TPE alone. So this is a new antibody which is described, that is caplacizumab, which is a anti-VEGF antibody which binds to the activated A1 domain along the ultra-large von Willebrand multimers. This will lead to inhibition of platelet binding, thereby improving the platelet counts. So and this is the Hercules trial. This is a landmark trial which led to the introduction of caplacizumab for immune TTP. So the chances of normalization is more than 1.55 times as compared to placebo. And the median time to normalize platelet is approximately 3 to 4 days as compared to placebo, where the median time to normalize is approximately 6 to 7 days. The secondary endpoints, that is composite of TTP-related deaths, recurrence in thromboembolic events, there was 74% reduction as compared to the placebo. So it definitely has some adverse events, particularly mucocutaneous bleeding, which is manageable. The only issue is the cost factor. So if you consider the cost, a single dose of caplacizumab would cost around 6.1 lakhs, and the entire course of therapy would be 2.7 lakhs, which is not feasible for our setup. So the long-term trial data also says that there are no new safety concerns and it can be reintroduced without any major issues. So initial treatment of TTP, if you are having any of the high-risk features, that is neurological abnormality, elevated troponin, as in our case, or decreased level of consciousness, please start Plex. Along with that, you need to start methylprednisolone. Within the first week, we will get improvement, or the lab values would come back if the ADAMTS13 is less than 10%. And if you have a clinical response, that is platelets of more than 1.5 lakhs and reduction in hemolytic parameters, there is disease response. If there are none, then you label it as a refractory disease and you start the patient on caplacizumab or rituximab. Uncertain diagnosis, stop or discontinue treatment. So after initial response, we need to discontinue Plex. Do not remove the central catheter immediately. You should remove it after waiting for approximately 3 to 4 days, and you observe for exacerbation. So if the exacerbation, if you are not able to find out any other new causes, that is catheter-related bloodstream infection or a drug-induced thrombocytopenia, please label the patient as refractory and start on high-dose steroid, if not started on high-dose steroid, and introduce rituximab and caplacizumab if available, which is not in our setting. So if there is activity and the activity improves, we need to taper the glucocorticoids over 2 to 3 weeks and initiate or complete a course of rituximab and continue platelet monitoring. And we need to extend the monitoring interval. So what happens after an acute episode? We need to assess the ADAMTS activity in the acute phase weekly basis, then followed by every 3 monthly. Preemptive rituximab should be introduced in patients who are having ADAMTS13 levels of less than 20%. And patients with persistent or severe ADAMTS13 at more than or equal to 6 months following first rituximab infusion are considered to have unresponsive to rituximab. So we need to know what are the outcome definitions. Exacerbation is decrease in platelet count or new organ or progressive organ injury in less than 30 days of cessation of Plex or anti-VF therapy. Relapse is more than 30 days with documentation of ADAMTS13 deficiency. Response is again sustained platelet count of more than 1.5 lakh with improvement in LDH to less than 1.5 times the upper limit of normal without any new or progressive organ injury. Remission is sustained clinical response with no plex or anti-VWF therapy for more than 30 days or attainment of ADAM TS13 remission. So before labeling the patient as refractory, we need to rule out confounders, that is wrong diagnosis. Either we are dealing with sepsis or DIC or anything else, or we have an alternative explanation, particularly if you're having a malignancy which is on board, or incorrect or suboptimal therapy, as we had discussed earlier, if the plasma is not being used as the replacement fluid, or if you are adding albumin to maintain the hemodynamics. So to label it as refractory, no improvement post 5 sessions of plex and steroids, as in our case, she was a refractory TTP. It requires escalation of therapy and initial response followed by deterioration. So these are the latest definitions for refractory TTP. So the management first line, as we had used in this case, high dose MPS. Twice daily plex is again a controversial part because many of the time patient wouldn't tolerate a twice daily plex because of the labile hemodynamics. And caplacizumab can be used as a first line agent, particularly in refractory TTP. And rituximab we can dose at weekly basis, or we can use a short abbreviated course. Second line therapy, all of these therapies would take more time to the response to kick in. Particularly rituximab takes approximately 10 days. And the second line therapy is vincristine and cyclophosphamide, NAC, CSA, and IVIG. So the long-term outcomes are neuropsychiatric manifestations, pregnancy-related complications. We have thrombotic events involving the cardiovascular and the cerebrovascular system. And globally, these patients have reduced quality of life, shortened survival, and fatigue. So this was about immune TTP. Coming to our next case, now it is a 14-year-old male who did not have any prior comorbidities, admitted again outside to a hospital with fever and diarrheal illness of 2 days duration, pain, abdomen, and recurrent episodes of vomiting, referred to as a case of complicated dengue. Patient was clinically unremarkable, peripheral smear showing 3% of schistocytes with anemia and thrombocytopenia, high LDH, creatinine 2.3, indirect predominant hyperbel, coagulation screen normal, tropical PCR panel, tropical infection PCR panel was negative. So our working diagnosis was diarrheal illness, probably infection-related HUS. We waited for approximately 48 hours and platelets improved, creatinine settled down, LDH dropped. Samples were taken, the diagnosis was not clear. So we had worked up in the lines of autoimmune as well as congenital TTP. So he was asymptomatic for a week and counts improved, platelets normalized, PS showing less than 1% of cystocytes, creatinine improving, and LDH also normalized. So on the day prior to discharge, he developed low-grade fever, which was followed by hyperacusis and visual disturbance, and GTCS and altered sensorium. NCCT head was normal. Shifted to ICU. Within the next 6 hours, patient becomes anuric. The repeat labs is bicytopenia, decrease in hemoglobin, drop in platelets, 8% histiocytes, creatinine 5.4, LDH 2300, started on plex. So post 3 sessions of plex, improvement in sensorium, urine output improved to more than 1 liter, and LDH drop. Injection methylprednisolone was added, suspecting that he was having a bad disease. So by that time, we got back our labs back. ADAM TS13 was normal. Low C3, C4 was normal. And here anti-CFH titers was more than 15,000. The other infection-related workup was sterile. MRI brain was normal. EEG, because of the prolonged post-ictal phase, we did a bedside EEG, which did not reveal any epileptiform discharges. Post 14 sessions of plex, near normalization, switched to oral steroids. And he was given monthly endoxan because of high anti-CFH titers. And the plex was tapered over the next 4 weeks, and steroid also was tapered. And renal function normalized, and he was asked to advise for OPD-based follow-up. Nearly after 4 months, he lands up in the emergency again with hypertensive urgency, papilledema. However, there was no hemolysis and platelet counts were normal. Serum creatinine was 1.7. Renal biopsy was done at this point of time, which showed chronic TMA with anti-CFH titers of 3,300, and he had developed CKD. So HUS and complement-mediated HUS, it is a thrombotic microangiopathy with significant kidney damage because the complement gets deposited predominantly in the renal endothelium. A typical HUS is followed by infection, whereas an atypical HUS may be related to complement system mutations or autoantibodies. Secondary HUS can occur as a part of other autoimmune disorders. So the scales are balanced, where inhibitors and activators are nearly on the same line, and they are at risk for once the scales tip over or there is a gain of function of mutation along the activation side. And the second hit happens either with the infection, inflammation, surgery, or autoimmune disorder or a pregnancy. Then the scales tip over. There is complement activation leading to downstream events leading to endothelial injury and platelet aggregation. So atypical HUS is frequently a two-hit disease, which there is a predisposition followed by a trigger, which leads to a complete phenotypic manifestation. So this is again a figure which shows when you have regulators which are active more than the regulators are more active more than the activators, there is no pathology. When the activators are more than the regulators, as we can see, there is secondary HUS or a atypical HUS. The manifestations can be pleomorphic, predominantly renal, as in our case, hematological manifestations, you can have mechanical hemolytic anemia. And in our case, we had visual disturbance, we had hyperacusis. Sometimes patients may present with stroke, confusion, or headache. And malignant hypertension secondary to the renal involvement. This may lead to pulmonary manifestations in the form of pulmonary edema, and GI manifestations can also be there as a part of atypical HUS. So the genetic abnormalities, the most common ones are CFH-related mutations and MCP-related mutations. The most important thing to note here is, apart from the MCP-related mutations, the long-term outcome, particularly with regards to death and progression to end-stage renal disease, is extremely high. So majority of the time it is anti-complement therapies. Only if you are having a CFHR1 or 3 mutations where your typical antibody removal along with immunomodulation works. Other than that, the prognosis being extremely poor on a long run. So if you have an acute phase of HUS, the minimum basic investigations which need to be sent is a complement level, ADAMTS13 activity, and anti-factor H antibodies. And you need to start the patient immediately on Plex. And if the ADAMTS activity is more than 10%, as in our case, diagnosis of atypical HUS comes in. So if a patient is severely oliguric, you may start the patient on complement blockade without complete workup. So we need to assess on a periodic basis, particularly with CH50 and percentage levels. And if there is hematological remission, then decrease in improvement in renal parameters, continue short-acting this thing, or otherwise contemplate a kidney biopsy. So coming to the anti-complement therapies, here we have 3 pathways we had already discussed. The terminal complement pathway, which we commonly know, particularly preventing the formation of the soluble C5 to C9 complexes or the membrane attacking complexes, where we have eculizumab, ravulizumab, and crovalimab, and C3 blockade, which is particularly for breakthrough hemolysis from the C5 blockade. We have pegcetacoplan, and we have the oral complement inhibitors, particularly particularly blocking the alternative pathway, that is danicopan and iptacopan. Then the lectin pathway or the MASP2 inhibitor, that is the mannose-associated proteinase 2 inhibitors, that is narsoplimab, which is particularly important in the use for complement-mediated thrombotic microangiopathy in transplant setting. So coming back to our case, we have anti-FH antibody-associated illness, which accounts for approximately 50% of pediatric atypical HUS. The genetic screening is required for if a patient is having onset before 4 years of age, relapsing course, and family history of HUS, and plex refractory illness. We did not do this thing because he did not match our initial criteria. The database on 436 patients from the group led by Dr. Baga, which shows anti-FH disease shows high antibody titer onset, delayed plex and short duration of plex predict adverse outcomes. So timely institution of plex, that is 60 to 75 ml per kg, and FFP should be used as an exchange fluid. Is the most suspected this thing. Then immunomodulation with IV steroid pulse if the sensorium is poor, or oral steroids if he can tolerate oral intake. IV cyclophosphamide on a monthly basis, that dosed at 500 mg per meter square for 5 doses. Then the maintenance should be prolonged with either MMF or Azuran or next 1 to 1.5 years to reduce the risk of relapse. So coming to the third, that is, I would be covering the TMA spectrum in pregnancy. So the primary TMAs are TTP and HUS. The TTP can be either inherited and acquired, as we had discussed earlier. If a TTP particularly presenting in the first pregnancy, you should consider congenital. Then the TMA mimics or overlaps, where you have HELP, eclampsia, sepsis, DIC, postpartum hemorrhage, or AFLP. So coming to our first case, that is a patient who is primary gravida, which is a 24-year-old female. She had documented platelet counts from 30 weeks of gestation, hypertensive blood pressure recordings, and rest was unremarkable. So she was evaluated in outside hospital where the platelet count was found to be less than 20,000, peripheral smear showing 1% of schistocytes, elevated LDH, and urinary ME was showing protein of 3+ with Coombs negativity. So suspecting a hypertensive preeclampsia with severe features, she underwent emergency LSCS for fetal distress at 34 weeks of period of gestation. She developed worsening thrombocytopenia and AKI post LSCS, transferred as a case of sepsis with MODS to our hospital. So again, first pregnancy, we have a worsening situation here post delivery or post LSCS. We had suspected a TMA disorder. Post-admission, developed FAC and altered sensorium. The imaging, including a CT venogram, was normal. She was immediately started on Plex. So post 2 sessions of Plex, there was dramatic recovery of platelets and renal functions. So our working diagnosis, we revised it to TTP more than complement-mediated HUS. And the second provisional diagnosis being probably a PESF. So the labs came back. ADAM-TS activity was 5%. There were no ADAM-TS antibodies. Autoimmune workup was negative. The complements were normal. Sequencing was not done due to financial constraints and switched to plasma infusions, counseled and discharged. So TTP and CMHUS in pregnancy is extremely rare as compared to other or TMA mimickers. So this is a master sheet or a cheat sheet for any pregnancy related events, particularly where we are dealing with thrombocytopenia and anemia. So here we can consider that TTP and complement mediated HUS and systemic vasculitis along with DIC, they may worsen post-delivery, whereas the TMA mimickers, they improve post-delivery. So in our case, she was in late 3rd trimester, she was worsened after 72 hours postpartum. She had severe neurological improvement. The platelets were less than 30,000. Severe LDH increase. The creatinine is usually less than 1.1. One important thing to note over here is in pregnancy, the upper limit of creatinine is rounded off at 0.87 or 0.9. Any creatinine beyond that is considered abnormal. And effect of delivery, possible worsening, that is 48 to 72 hours postpartum, as happened in our case because there is a precipitous drop of ADAM-TS level post-delivery. So TTP in pregnancy, the organ involvement being CNS more than renal and cardiac involvement can also be there. The ADAM-TS13 levels are less than 10%. So as an autoimmune disorder, acquired TTP typically affects young women, mainly in the 3rd and 4th decades. However, sometimes postpartum TTPs, they generally present as acquired TTP. On the other hand, a large proportion of adult onset congenital TTP, they debut in their first pregnancy. So the risk factors for why patients of congenital TTP present in the first pregnancy, the VWF level steadily increased during pregnancy with a drop of ADAM-TS13 levels starting from the 2nd trimester until a few days after delivery. And sometimes we can have a precipitous falls of ADAM-TS13 level, and that lead to more dramatic presentation or worsening after 48 to 72 hours. So these changes can promote the disease in congenital ADAM-TS13 deficiency. So again, acute TTP can also be there as a part of pregnancy because of the semi-allogenic fetus leading to immune tolerance, and the TTP can also be linked with other autoimmune disorders which can appear before or during or after pregnancy. So presentations, generally it presents after 30 weeks, 2nd trimester presentations around 38% and less than 20 weeks. So if any TMA is there within the 1st trimester of pregnancy, please consider TTP, particularly the congenital TTP can present in the first thing, or postpartum TTP acquired is more than congenital TTP. So symptoms again, proteinuria as in our case, then neurological symptoms, headache, TIAs, blurred vision, then dramatic presentations or acute collapse are more common with acquired TTPs in pregnancy. So onset is typically explosive or hyperacute, whereas in our case, there was a gradual onset of thrombocytopenia, which preceded overt hemolysis, and look for subtle CNS involvement and bad obstetric history. So congenital TTP is rarely diagnosed, and in our case, there was quick platelet recovery from the plasma exchange, which may indicate that there is no anti-ADAM-TS antibody present in circulation. So if a patient asks you whether she can conceive later, yes, the answer is yes, but there is a risk. The relapse risk is 100%, and the subsequent pregnancy cannot proceed without plasma infusions. So if she's willing for pregnancy and she's pregnant again, the plasma infusion should be started 2 weekly till 20 weeks and then continued weekly till 6 weeks of postpartum. Supposedly, if we are having an acute TTP in pregnancy, acquired TTP in pregnancy. Azoran and the calcineurin inhibitors are the mainstay of immunomodulation. If it is refractory, and the delivery should be expedited, allowing room for rituximab use. There is no safety data on caplacizumab, so it should be avoided for pregnancy. So subsequent pregnancy in autoimmune TTP is the key central figure is 20% of ADAM TS13 level is minimum required. If it is less, please use preemptive rituximab, and the preemptive rituximab should be minimum 6 months, and ideal is 1 year prior to next pregnancy. And the monitoring should be at least each trimester. We need to have 1 levels and routine blood counts and monitoring. If the levels drop to less than 10%, please consider elective treatment, including PLEX and hiking up the immune modulation with IV steroids. So coming to our second case, that is in the pregnancy related spectrum, we are having a patient who's having recurrent pregnancy losses, who's already having 1 living child. She's at 28 weeks of period of gestation. She has pain abdomen and bleeding per vaginum since last 1 week, last 1 day. She underwent cervical encerclage at her hometown animal and worsening PV bleed. So clinically pale, you have bicytopenia, creatinine is 4.3, AST/ALT is high, you have features of hemolysis, and after that, the ultrasound pelvis done at her home station shows abruptio placenta, immediately taken up for LSCS. Generalized worsening of health and lab parameters turns oliguric, receives component support, shifted again to our unit as a case of postpartum sepsis, to our hospital as a case of postpartum sepsis and MODS. Admitted to ICU in view of fluid overload, anuric and hypotensive. She continues to have high-grade fever. Labs again shows bicytopenia along with leukocytosis. She does not have any features of hemolysis. Creatinine is 8.5. Started on hemodialysis in view of fluid overload and elevated creatinine. Then there is worsening picture in day 2 to 3 of ICU stay. She worsens, LDH peaks high. There is mechanical hemolytic anemia. PLEX is added to the already existing RRT. Autoimmune workups and the differential diagnosis at this point of time was CAPS was a consideration because of a recurrent pregnancy loss, and HUS because of a prominent renal involvement, continues to be anuric, and her tolerance to PLEX and RRT is poor because of ongoing hypotension, which requires maintenance of MAP with pressor support. We have cultures which is flag for E. coli in the urine, and post 8 session of PLEX and HD non-oliguric, the lab parameter stabilizes, the blood culture sensitivity returns as pseudomonas aerogenes are related, sepsis, and antibiotics were tailored accordingly. Endocervical swab returns as E. coli. The TMA workup comes back. We have low complement, low CH50 titers. The anti-CFH titers were negative and NGS was sent. There is a resolution of infection in blood and urine. Cultures were steroid. So she was started on steroids, despite the anti-CFH titers were negative because we did not have any other agents to give her. She became dialysis dependent. The blood pressure was optimized on therapy. Renal biopsy due to persistent azotemia, features of chronic TMA, and the IFTA was graded at 10 to 15%. NGS panel came out to be negative, and the final diagnosis, we gave it as complement-mediated TMA, abruptio placenta, and sepsis. So again, coming back to our master sheet, so complement-mediated HUS worsening after postpartum, creatinine goes roof high. There is in this case, we had hypotension because of ongoing sepsis, and it is rare in the first half of the pregnancy. So what are the role of complements in pregnancy? So it is way from implantation to parturition. It is important. Normal pregnancy, there is a revised homeostasis. There is increase in C3, C4 and the factor X level. There is no increase in soluble membrane attacking complex. The classical pathway is involved in trophoblast migration, spiral arterial remodeling. The lectin pathway, as we had discussed earlier, it helps in removal of the apoptotic cells, particularly during the syncytial trophoblast stage, and it promotes normal placentation. So particularly in preeclampsia, which is as in our case, there is defective trophoblast invasion of the spiral arteries that leads to placental ischemia and complement dysregulation on top of it because of inadequate clearance of the placental debris because of the alteration of alternative pathway that leads to systemic inflammation and endothelial dysfunction. So how do you manage a patient who has suspicion of TMA or pregnancy? So you rule out the mimickers, you can do a prompt delivery and symptomatic management and blood pressure control. So if there are no prominent cardiac or neurological symptoms, she can be closely observed in ICU. Alternative diagnosis may be sought like sepsis or postpartum hemorrhage, and the treatment can be channelized towards that. If she has prominent neurological and cardiac symptom with profound thrombocytopenia, please start PLEX. And if there is improvement in the thrombocytopenia or hemolysis more than 25% from the baseline creatinine, then the likelihood of TMA is unlikely. We need to continuously monitor. And if it is not improving, please start plex and do the TMA workup, particularly the ADAM-TS13 level, which is central figure. And if it is more than 10% complement mediated TMA, we need to discontinue plex and switch to a complement based therapy. If it is less than 10% and you check for the antibodies, if it is antibody positive, then you do immunomodulation with continuation of plex. And if it is negative, you continue plasma infusions. So it is defined by 3 features as we had discussed earlier. The most important thing is the clustering of events, particularly around delivery and postpartum. Case reports have been there till 12 weeks of postpartum complement mediated HU scan present. So short-term outcomes, no maternal deaths, 14% of fetal mortality, ESRD within 3 months, and eculizumab can be used and it will lead to full renal recovery. So long-term outcomes on a 7-year follow-up, most 50% of them follow to end-stage renal disease, and 19% of the patients with eGFR of less than 60 ml did not develop ESRD. So hemolytic uremic syndrome, there was no statistical difference in outcomes, particularly if the complement factor detected, not detected, plasma exchange given, not given, or HUSs during pregnancy or postpartum. So a brief on eculizumab in pregnancy. There are no trials to suggest the safety of eculizumab in pregnancy. However, there are case reports describing its use and safety. So the subsequent pregnancy, definitely if a patient asks after acquired HUS, after atypical HUS, the relapse is around 25%. The key central figure is anti-complement mediated therapy. Prophylaxis with anti-complement therapy is currently not advised. So what are the other concerns? Platelet transfusion, yes, it is a big gray area, particularly you would require, particularly for obstetric indications, as well as the venous access required. And plasmic score is not validated in pregnancy. Kindly do not use plasmic score for predicting ADAM-TS13 deficiency. Delivery as well as the delivery route, it is totally an obstetric indication. The hematologist or the hematological impact from TTP or any other this thing is not required. We can support the delivery by advising them SDAP transfusions prior to delivery or intra-op and post-delivery to prevent major bleeds. So again, coming back to the counseling during pregnancy, regular plasma infusion, and vaginal delivery, continue plasma infusion, particularly in congenital TTP for minimum of 6 weeks. Acquired TTP, you monitor the ADAM-TS levels, and if it is less than 10%, prophylactic plex with immunomodulation is the keystone for managing this kind of patients. Coming to the last set, the dangerous DUA. So here you have, we are dealing with the malignancy as well as the transplant-related TMAs. So here we have a 63-year-old female who was hypertensive, multiple comorbidities, metastatic CA colon, post multiple lines of therapy on palliative agent bevacizumab. She is admitted for evaluation of altered sensorium visual disturbance of 1-day duration, suspected main beds or press because the blood pressure at admission was 230/110. Imaging normal. So the labs come back. PBS shows 4% of schistocytes with bicytopenia. The coagulation parameters are within normal limit. Coombs negative. Creatinine is high at 3.9. Samples taken. And we did not initiate plex. The bevacizumab was withheld. Aggressive blood pressure control using nitroglycerin infusions. ADAM-TS activity was found to be at 42%. Complements normal. And hemolysis improved. So the sensorium cleared after almost 4 days of testing. And renal functions improved on withholding the bevacizumab. So final diagnosis, we queried at drug-related TMA. Again, this is a nebulous area which is seen in approximately 15% of patients, the most common being metastatic malignancy, more than drug-related. The key figures are MAHA plus thrombocytopenia plus AKI, diagnostic confusion because of the underlying malignancy or ongoing chemotherapy, which can also explain the cytopenias, renal dysfunction, and infections on board secondary to the immunomodulation or the chemotherapy related effects. So cancer-induced TMA can be because of systemic microvascular tumor emboli, particularly the adenocarcinomas are notorious. We can have DIC secondary to low-grade DIC, which can happen as a part of metastatic malignancy, or carcinocythemia, or where there's diffuse bone marrow infiltration, which may lead to cancer-induced TMA. Drug-induced TMA, again, the mechanisms have been described. Primary TMA, This is a trigger. Cancer is a trigger. Already having underlying predisposition, particularly ADAMTS13 deficiency or a complement-related gene mutations, this may lead to primary TMA. The common malignancies are solid malignancies, gastric, breast, and prostate, which are the key figures, and lymphomas in hematological malignancy, approximately 8% of patients where we can have. Cancer-induced TMA, the figure, please note that respiratory involvement is quite common and pain is very severe as compared to your routine other TMAs. And the anti-neoplastic agent induced TMA, since we are covering this, lenalidomide and the checkpoint inhibitor ipilimumab, they converge on ADAMTS13 deficiency that responds to plaques. Mitomycin and gemcitabine, they respond to complement inhibition. And proteasome inhibitors, particularly we use for multiple myeloma, they have renal impairment with hypertension and TMA, drug withdrawal, as well as they respond to complement inhibition. Platinum salts, they can lead to drug-dependent antibodies against platelet and RBCs, leading to bicytopenia and TMA. So in our patient, we had anti-VEGF therapy-related type 2 cancer drug-induced TMA. It can occur at any time, and there is complete reversibility of this thing after drug withdrawal, and rechallenge is additional data is required for the survival, for the introduction again. So the kidney survival rate and the patient survival rate is extremely good after stopping the drug in association with aggressive blood pressure control. Coming to the transplant-associated case, here we have a 18-year-old male who was diagnosed to be having severe aplastic anemia with availability of 12 by 12 matched sibling donor. Transplant, he undergoes transplant in the month of March with a conditioning protocol, flu-cy ATG. He gets engrafted and he is discharged from the transplant unit on day 32. On day 50, he returns back with bicytopenia, peripheral blood showing 6% of schistocytes, and he having renal dysfunction along with hemolysis parameters. The viral serologies are negative. There is no DIC. Cyclosporin was withheld, and day 50 chimerism was 100%. Bone marrow was done to look for any HLH. So there was no features of HLH, and the bone marrow was having 80% cellularity. So with the given restricted therapeutic options available, we decide to pulse the patient and hope that he might be having anti-CFH mediated complement mediated HUS. 5 sessions of plaques, there is minimal improvement in blood parameters. IST switch to MMF. ADAMTS13 levels activity comes back at 33.5%. Autoimmune workup is negative. He has nephrotic range proteinuria. Final diagnosis was TA-TMA sequencing, no pathogenic mutation, and he was discharged on request because the prognosis was extremely poor. So again, TA-TMA is a combination of both TTP and CMHUS. It is an endotheliopathy, basically the endothelial dysfunction. It is a 3-hit disease. We will be discussing in that. It carries a high mortality risk of 40 to 84%. It is again a significant challenge to diagnose because there is a lack of consensus on diagnostic criteria. So again, the first is at the preconditioning phase where we have infections, indwelling catheters, or the growth factor administration and and genetic predisposition. The second is the conditioning where we use TBI-based regime or flu-based regime or high-dose busulfan. And during the third hit, the patient is in aplasia, recovery phase. You're having onboard infections, ongoing exposure to the immunosuppressants, that is calcineurin as well as mTORIs. That leads to the third hit, and it ultimately culminates in microvascular thrombosis. So what we follow is the International Working Group of Thrombotic Microangiopathy, schistocytosis of more than 4%, along with de novo anemia, thrombocytopenia, as in our case, with undetectable haptoglobulins with increase in LDH. The other groups also have included proteinuria and hypertension as a part of TMA diagnostic criteria. So the management being BP control, support renal functions. You need to support erythropoiesis with optimal transfusion, managing potential triggers and removal of CNI and sirolimus if possible, and introduction of MMF, then autoantibodies with either steroids, particularly anti-CFH antibodies. The component blockade is the keystone, particularly eculizumab and narsoplimab, as we had discussed earlier, which is a MASH2 inhibitor in high-risk TMAs. So coming to the mimickers, none of the above. Again, a 22-year-old female, she was referred from outside hospital. She is symptomatic anemia of 2 months duration, schistocytes in circulation. She has indirect predominant hyperbilirubinemia without any evidence of renal dysfunction. And provisional diagnosis of TMA was given from the outside hospital, was transferred for introduction of plaques. Our hospital evaluation, MCV of 119 femtoliters, MCH of 31, no atypical cells, Coombs negative. We labeled it as probably nutritional anemia secondary to megaloblastic anemia, probably underlying B12 deficiency or Evans syndrome, because sometimes Coombs negative Evans can also coexist. Vitamin B12 came back at 50, started on B12 and oral folic acid supplementation, better after 5 doses, after 2 weeks of hospitalization and near complete recovery of cytopenia, and final diagnosis pseudo TMA due to underlying vitamin B12 deficiency, and she was discharged. So coming to the zebras, DIC can be due to underlying sepsis, which is very common, or because of underlying abruptio placenta or pregnancy-related complications, or any underlying carcinomas. These can have schistocytes in circulation and a picture very similar to a primary TMA. Malignant hypertension is another. Aggressive blood pressure control. If there is no improvement of renal parameters or sensorium, kindly do a TMA workup. And drug-induced TMAs are another zebras, which is very important. Coming to the controversial topic, that is platelet transfusions in TMA. So most of the case reports have been described prior to the Plex era. In practice, in daily routine clinical practice, we would require platelet transfusion. As in our case, she was having a IC bleed along with that insertion of venous access for Plex. So the TTP registry from the Oklahoma, almost 60% of the patients received platelet transfusion. There was no incidence of any increased death who received and did not receive platelet transfusion. And the bias of only baseline disease, more severe disease requiring platelet transfusion is not very clear. And withholding platelet transfusion, they did not show any improvement in mortality. So institution policy, keep it as at least safe limit to prevent spontaneous bleed and for procedures. That is the main thing. So I complete my presentation. Thank you so much.
Thank you, Dr. Ranjit. Wonderful talk. You have covered almost everything regarding the TTP, starting from the pregnancy-induced TTP to the classical TTP to the drug-induced TTP, malignancy-associated TTP. That's fantastic. I think we'll have many questions now on this basis, and I request all of our discussants to please put the hand raise signs so that we can start our question session with Dr. Ranjit. Dr. Ranjit, if you can just unshare your screen once.
Sorry?
Can you please unshare your screen?
Shall I close the presentation now?
Yeah, you can close your presentation. You can unshare your screen.
Okay, yeah. I've stopped sharing.
So we can see each other. There is one question from the audience. This is regarding, this is from Dr. Naresh Tide. If atypical HUS can does atypical HS can present as PRESS and AKI suddenly without thrombocytopenia?
So as we had discussed earlier, malignant hypertension, AKI, if not improving within 48 to 72 hours with aggressive blood pressure control and no improvement in sensorium, kindly consider a diagnosis of TMA, and we need to start workup for TMA, because otherwise we will lose time and we will lose the patient.
Perfect. Another question is again from Dr. Naresh Tade. What level of LDH would you raise a suspicion of HUS? Can LDH be totally normal in HUS?
It's unlikely to be normal in completely normal as compared to if you see TTP versus HUS. The LDH levels are quite high. Particularly, it is more than 8 times the upper limit of normal LDH. So LDH generally is not normal. So if you see the pregnancy-related events also, pregnancy itself cannot increase the LDH. So that claim towards that pregnancy may lead to increase in LDH is totally wrong. So LDH in most of the cases, or maybe we can somewhere figure it around 99% of cases is high. So with normal LDH, unlikely, or the diagnosis is something else.
And you are convinced that atypical HUS can occur without thrombocytopenia also?
It may present initially, and later on the features may evolve. So at presentation, you can have an entire spectrum of presentation, right from altered sensorium, hypertensive crisis, or renal failure, and gradually the thrombocytopenia can come up. So at presentation, so that is the reason why we closely follow up all these patients. No improvement within 48 to 72 hours. Kindly think it as a TMA and do not leave the patient as that it is a malignant hypertension or a pregnancy-related complication. Do introduce plasma exchange. That is my understanding to this disorders.
Thank you. And there's a next question from Dr. Ramaswamy regarding caplacizumab. how early it should be started, and how late, if we are starting, should be effective?
Thanks so much for that question. I don't have any personal experience in using Caplacizumab, but whatever from I have read, so if it is as we had discussed earlier, if it is a severe TTP or a TTP who's having upfront neurological dysfunction, patient is sick to the bed, and patient is having high troponins, kindly introduce Caplacizumab if available with you before the first session of Plex. And you need to continue Caplacizumab. The loading dose is 10 mg IV prior to the onset of Plex, and after that 10 mg subcutaneous post each session of Plex. The likelihood of platelet recovery is extremely good. You can reverse the entire thing in a matter of 72 to 96 hours, and the patient will improve. So if available, kindly introduce for immune
My one doubt is, will it be effective even after the von Willebrand factor bind to the endothelium? Whether it is a loose as well as bind endothelium, both are effective?
No, it is effective. It is effective.
Okay,
And
thank you.
so even after 5 sessions of Plex, no improvement, you can introduce Caplacizumab.
Thank you. Dr. Kunal Chetani, your question, please.
Hello, sir. My question is about rituximab. Do you add rituximab to all the patients upfront?
This is again a
Got it.
controversial question. So see, as we had already discussed earlier, so if you're seeing a platelet recovery within 1 to 2 cycles of Plex,
Yes.
that generally doesn't happen with immune-mediated TTP. That has to be a congenital TTP. It is not your Plex which has worked. It is the plasma infusion which has worked. If you go the other way around, if there is no improvement, by day 3, you should suspect, because if you look at the statistics, acquired TTP is more common in adults than congenital TTP, and you should introduce Plex, because the time for the rituximab effect to kick in would be minimum 10 to 14 days. So if available and if finance is feasible, please introduce rituximab suspecting an immune-mediated TTP based on the statistics as well as your platelet recovery post. At least by 48 hours, you would come to know what you are dealing with.
If the patient is not improving, when you will consider twice daily plasma therapy plasma exchange? Have you done it?
So the data is there for twice daily plasma exchange, but in our setting, generally they don't tolerate. Even the ongoing Plex is poorly tolerated because most of our patients were on vasopressors during plasma exchange. So you increase the plasma exchange volume from 1 to 1.5 and kindly use completely fresh frozen plasma, because generally the plasma exchange who is offering you plasma exchange, the nephro team or the blood bank team would say that kindly use albumin because the pressure is low and all those things. Kindly use fresh frozen plasma as a replacement fluid. That would take care of the thing. So twice daily, if it is a refractory Plex, after 5 sessions of once a day Plex with steroids, you can consider if hemodynamics is permissive.
Okay. And do you do plasma pheresis tapering, like kind of thing? The patient responding, and you taper, or do you directly stop?
So there are 2 schools of thought to it. Plasma exchange has its own set of side effects. The vascular access related thrombosis infection and poor tolerance to Plex, then your anticoagulation related citrate toxicity and other events. So 2 schools of thought. Some of them do completely stop after achievement of clinical response, that is platelets of more than 1.5 lakhs and LDH, which is an improvement in hemolytic parameters. So do not remove the line. That is my advice to you. Do not remove the line upfront. Wait for at least for 72 to 96 hours. Look at the parameters, whether you are having a clinical exacerbation, that is drop in platelet count. Any variation in platelet count of more than 10%, kindly consider that the patient is moving towards exacerbation and you may require introduction of Plex again.
Thank you, sir.
Thank you, Dr. Kunal. Dr. Ranjit, do you have any algorithm managing refractory TTP?
Refractory TTP, I had actually hid slides because the slide numbers were too.
Third line, what should we add?
So
real world scenario in India.
Okay.
Capla is not available.
Okay, so the first line would be high dose steroids, methylpred pulse, and by day 5, patient not improving, please introduce rituximab at 375 mg per meter square. Again, dosages can vary. You can abbreviate the dose by day 1, 4, 8, and 15. This is one way. And second is, you can, in a routine clinical practice, if you want more of immunomodulation, no response after introducing this. So kindly add, I would say, vincristine 1 dose, 1.4 mg per meter square as a single infusion, and cyclophosphamide to be followed by WIC. So we would be something on a RCVP kind of protocol here. So this is a way we can come around this refractory TTP. But if we don't introduce, or if we are late even by a day or two, we generally tend to lose the patient. So here in this case, the patient was admitted. In the first case, the patient was admitted almost for 8 days in an outside hospital, then came to us again, admitted for bicytopenia evaluation, then altered sensorium turned around. So that is a way. So my take would be introduce MPS as a first line and rituximab as first line, particularly if you're not seeing clinical response. Even if it is a acquired TTP or an autoimmune TTP, which is not labeled as refractory, your rituximab would help in prevention of important clinical relapses. The relapse rate will come down to less than 20%. So rituximab, yes. High dose methylprednisolone pulse, yes. Then not improving, kindly add a CVP kind of protocol, because already you would be on steroids, and along with that VCR 1 dose and cyclophosphamide 500 to 750 mg per meter square on a weekly basis. This would be my management.
Any role of bortezomib in your algorithm?
Bortezomib, yes, because if not improving, the rituximab depletes the B cells, where if you're targeting the plasma cells, you need to have bortezomib. If not improving, we can introduce bortezomib also. So bortezomib may be dosed at 1.4 mg per meter square, again at 72 hourly intervals in a very short span. By day 11, you should be out of bortezomib. So that would eliminate the plasma cells, which would cause the antibody production. So it is like you are blocking the plasma cells, as well as the B cells are again depleted by rituximab. So,
and about cyclosporine?
Cyclosporin, there was, if you look at the trials, particularly the Spiro Catalan's group, so he had done a head-to-head trial with steroids as well as cyclosporin. So the exacerbation rates are relatively higher in the cyclosporin arm as compared to prednisolone arm. So I'm working in a government setup, and most of us would be working in a government setup. Steroids are handy because it is easily available. And if you have a cost analysis, that would be definitely cheaper as compared to cyclosporin. So definitely my go-to drug would be steroids 1 mg per kg, which would be tapered over 2 to 3 weeks in case of an immune TTP with a significant clinical response. Or if required, if poor tolerance to again steroids, then cyclosporin can be introduced, but I would prefer steroids as compared to cyclosporin due to the feasibility in view of availability and finances, and the reduction in mortality rate as compared to cyclosporin, because cyclosporin has its own set of side effects. Hypertension, again, schistocytosis can be secondary to introduction of cyclosporin also. So again, there is a diagnostic dilemma there. So steroids would be my go-to agent.
And any literature on daratumumab in refractory settings?
Yes, there is literature is definitely coming up for daratumumab also. Again, it works on the principle that it is an immunomodulatory drug, particularly targeting the underlying plasma cells and the B cells. So daratumumab, yes, can be used, but generally because of the cost constraints, we restrict ourselves to rituximab in this thing. Yes, definitely, it has a third line agent. As a third line agent, we can use, or we may use. Again, it is again dependent upon the availability and finances, because Dara is an extremely costly drug, particularly for this thing. It can be used. I'm not saying it cannot be used, but I would definitely prefer prior agents like this thing. If it is unresponsive, definitely yes, daratumumab, yeah.
And those patients who are lupus positive, lupus anticoagulant positive, all the three positive, LA positive, ECLA positive, beta 2, GP1 positive. So any approach different from your normal approach in these patients?
So again, the key cornerstone would be immunomodulation. Would have a ongoing PEX. Along with that, if it is a triple positive APS, along with the TTP, immunomodulation would be key. With rituximab, definitely yes, and a steroid, which has to be tapered over maybe around 6 to 8 weeks, and a maintenance immunosuppression. Particularly, these patients are prone for relapse. And on top of it, I would like to add a low dose anticoagulation to prevent thrombotic events, because it is like a double whammy. You have TTP on one side and you have APS on the other side. So if not any, there are no documented thrombotic events, low dose prophylactic anticoagulation, yes, maybe with LMWH as a prophylactic this thing, or as apixaban in a low dose or a rivaroxaban in a low dose on a prophylactic dose, yes, I would consider adding anticoagulation on top of it. But the key or the spine of the therapy again remains immunomodulation with steroids, rituximab for relapse prevention, and maintenance immunosuppression with azoran or calcineurin inhibitor.
And how long do you continue steroids in TTP?
TTP, if we are out of the acute episode and ADAM-TS activity is more than 20% or between 20 to 30%, I would taper off the steroids by 3 to 4 weeks and watch for a relapse. Or in a high risk case where you know that patient would relapse, you add preemptive rituximab. So again, the relapse prevention is significantly brought down by introduction of rituximab. So steroid duration 3 to 4 weeks, and definitely a slow taper. If you see anti-CFH antibody-mediated disease in HUS, the taper is even more slower. So we need to have concomitant immunosuppression for anti-CFH, very high titers, either in the form of cyclosporin or maintenance maintenance azoran or maintenance cyclophosphamide. So immunomodulation is must to prevent relapse. Acute TTP, if significant response, ADAM-TS13 in remission, that is more than 20%, I would definitely taper off the steroids by 3 to 4 weeks.
Thank you. And what about anticoagulant and antiplatelets?
Anticoagulant and antiplatelets, most of the time we are in a, fix, because platelets are extremely low. We're having ongoing thrombotic events, so it becomes a thrombocytopenia, thrombosis kind of syndrome. So you bring up the platelets, again, platelet infusions, it has its own risk. And I would say if the platelets are more than 30,000, definitely you should add LMWH to it. Otherwise, even if at a prophylactic dose, or if the platelets are north of maybe 50,000, you can go ahead with a therapeutic anticoagulation based on the clinical situation. So if patient is having, like in our first case, she had a concomitant IC bleed. So again, we were not able to anticoagulate the patient. So ongoing bleed or bleeding events. So definitely that is a contraindication towards even a prophylactic dose anticoagulation.
So once you start anticoagulation, antiplatelets, how long do you continue those?
So again, anticoagulation, so now most likely it is a provoked event, like minimum duration of anticoagulation as per the existing guideline would be 3 months, may extend up to 6 months based on a clinical scenario kind of picture. Triple positive APS with past history of BOH, definitely I would say as a clinical practice, we would continue a low dose prophylactic anticoagulation to prevent a clinically relevant thrombotic event, or to prevent recurrent pregnancy losses during pregnancy or prior to pregnancy. You may switch to prophylactic LMWH.
So if the patient has proved to be triple positive, APLA, and patients develop TTP, recovered from TTP, you already started on prophylactic LMWH, and now you want to switch over to another one, and you want to continue for next 1 to 3 months, which anticoagulation would like to choose here? Because that's what we have a real world scenario now. Because triple positive, whether will apixaban work in such cases?
That's again a tricky question. So triple positive APS, no upfront data for DOACs. So conventional warfarin or a VK based anticoagulation is the drug to go. And the only flip side is frequent monitoring, challenges with INR, dietary indiscretion. But if the scenario is a triple positive APS, I would definitely go with warfarin or a acinocomerol based anticoagulation, not with a newer agents like apixaban, rivaroxaban. So the go-to agent would be a VK based anticoagulation.
Perfect. Anybody has any other question? Because there are no more questions in the chat box. Yeah, one question has come. Dr. Ramaswamy, you have a question? Dr. Ramaswamy, sir?
Yeah, if it is a APLA positive TMA,
Yeah.
subsequently, does it require anticoagulation? No need. Unless there is a thrombosis, no need of anticoagulation. Nah?
It's actually not required, but the chances of having a recurrent thrombosis is quite high, particularly with triple positive APS. So triple positive APS, the incidence of thrombotic complications are high. So minimum required duration would be a prophylactic anticoagulation. If there are no thrombotic events, we need to tide over the crisis and bring back the physiology to normal. So 8 weeks is the minimum duration to bring back the physiology to normal. So at least minimum duration from my side, a low dose anticoagulation up to 12 weeks may be considered. That too again, case to case basis. And if the patient is permissive, like without any prior bleeding events or anything, then definitely we would wait the physiology to reverse back, particularly in triple positive APS. There is this thing. The other flip side is all these APS markers can be transiently positive during this acute episodes, and the diagnostic criteria warrants a repeat of all these tests in another 12-week span to confirm that it is a primary APS. So during that duration, I would say I would like to continue this lower dose anticoagulation if there are no clinically relevant thrombotic events to prevent one major catastrophic thrombotic event. So because most of the patients would be young and female patients. So I would say maybe we will wait for 12 weeks till you confirm it as a triple positive APS.
Thank you.
I just want to add one thing, because there is a newly generated BCSH guidelines on APLA, which has just come up just 1 month back. And what they have said is the patient is presenting with APLA positivity and already diagnosed as TTP. It's actually a microvascular thrombosis, basically. And we may not be able to see the thrombosis as such, but strong APLA positivity, all the 3 lines positivity, APLA, ACLA, and lupus, all triple positivity. It has to be some anticoagulation should be continued for these settings, and the minimum period what they have given is 12 weeks. This is only for the lines of antiphospholipid antibody syndrome presenting as TTP. This is a new guidelines which has just come just 3 months back.
I just want to add one thing as our understanding improves. So many of the things are this part of the basic pathology only, rather than having a separate disease entity known as TTP or HUS. So maybe it is just part of that same disease spectrum which is manifesting in a different way. So till the reversal of physiology, as even the guidelines says, which I have not read. So even the guidelines also say like that. So till the reversal of physiology, I would say yes, definitely a prophylactic low dose anticoagulation to prevent clinically relevant thrombotic events is a must.
Perfect.
Thank you.
So we'll just wait for next 10 minutes and then we'll go with our third lecture, which will be last lecture. So thank you, Dr. Ranjit. Wonderful lecture, fantastic discussion, and your slides were beautiful. You covered almost everything in one go. Fantastic. Superb.
Thank
We'll
you so
wait
much.
10 minutes and we'll join again after 10 minutes for the third lecture. Thank you so much.
Thank you so much, Dr. Khuranan.
slides to be shown by as this session is being sponsored by Roche. Mr. Nikhil, if you can just share the slides. Yeah, we are able to see the slides. Okay. Should you unscreen the screen once then? Yeah. Thank you.
So we can proceed.
So this session, this is the last lecture, and this session is being sponsored by Roche on the bispecifics. And let me share the screen once again to all of you. So it's time to introduce our third guest speaker for the day. We are no other than Dr. Ramesh Balasubramanian from Madurai. Let me introduce him. He's a consultant and head Department of Hematology and BMT at Velamal Medical College and Hospital, Madurai. He did his MBBS and MD from the very prestigious Madras Medical College. He was a university topper and gold medalist in MD pathology. He pursued his DNB super specialty training in clinical hematology at Sir Gangaram Hospital, New Delhi. He has also worked as consultant hematologist and bone marrow transplant physician at Meenakshi Mission Hospital, Madurai. He started the Department of Clinical Hematology and Bone Marrow Transplantation at Velamal Medical College Hospital in Madurai, Tamil Nadu. He's the first one to do haplo-identical bone marrow transplant amongst the medical college hospitals in South Tamil Nadu. To name his awards and recognition, he received the best outgoing student and gold medalist in MD pathology from Madras Medical College in the year 2019. He's also commendable and best thesis award from National Board of Examination 2022 for his work on acute myeloid leukemia. He is winner of multiple quiz conducted at national conferences in hematology conducted by Mumbai Hematology Group, Delhi Hematology Group, and Indian Myeloma Academic Group, that is IMAGE. He was one amongst the mentees in European Hematology Association Master Class in the year 2024-2025 and involved in very active discussions. Today, he's with us and he's going to lecture us on bispecifics regimens which improve survival in large B-cell lymphoma. Well, thank you so much. I stop over here. Over to you, Dr. Ramesh.
Thank you, sir, for the very nice introduction. I thank Mumbai Hematology Group and MBA Girl sir also for giving me this wonderful opportunity. So let me share my screen.
Yes, we can see your screen. Please go ahead.
Yes. So this topic, bispecifics, which improves the survival in large B-cell lymphoma. When we come to large B-cell lymphoma, the response rate with the primary treatment will be the anthracycline containing regimen. Predominantly, it will be R-CHOP. The cure rate, the response rate is close to 70%. Two-thirds of the patient, they do very well. But still, one-third of the patient, they do not do well, or they are primary refractory, or they relapse within 2 years. And the survival of these patients who are primary refractory or who had relapsed within a year of the frontline therapy, the response rate is poor. The response rate is somewhere around 30%, as shown with these studies of Coral and Archer. And the relapse, even if they are transplanted with, they undergo autologous transplant, the relapse rate is even more, and the survival is very inferior. So, how do these lymphoma patients respond to therapy is, and what treatment we have to offer? We have to take into consideration the patient's factor, like whether they are eligible for transplant, what all the comorbidities the patient is having, and what is his performance status, what all treatment he has received previously, and is he eligible for transplant now or for a CAR T, and not to leave the disease nature, because primary refractory DLBCLs, they're usually chemo resistant, rather than a late relapse. So all these factors to be put into account or to take a treatment decision so that we achieve a very good response rate in these patients. So even this is a data which shows like even after scrutinizing these patients, 60% they do not go to transplant after salvage chemo due to multiple reasons, either because of the patient's poor performance status and exposed to multiple lines of chemotherapy, they're not transplant eligible. So this is the timeline to show the treatment evolution, the treatment of large B-cell lymphoma. So 1975 allogenic bone marrow transplant came way back in 1975, following which the Parma study established the fact that autologous transplant is superior to just subjecting the patient to salvage chemotherapy. Then came the era of CAR T-cell therapy. 2017 we had Axi-cell, which was approved for the third line, and Tisa-cell was approved of the third line in 2018, and 2019 we had polatuzumab with BR approved for the third line. In 2020 the approval of selinexor and tafasitamab, and 2021 we had the approval of liso-cell for the third line, or loncastuximab is also approved for the third line. And 2022 Axi-cell was approved for the primary refractory large B-cell lymphoma and for having a early relapse, and liso-cell was approved for again for the same indication and also for patients who are not eligible for transplant. And 2023 is a breakthrough. The bispecific came into this era from May 19. Epcoritamab was approved for the third line, and June 15 we had glofitamab approved for the third line. When we see the relapse rate following salvage chemotherapy, platinum-based chemotherapy, the response rate is somewhere between 40 to 60, but it's only with the chemo sensitive disease, that is late relapse is considered. And the CR rates following that chemo sensitive patients is also around 30%. So remaining 2/3 they don't do well, and the worst part is the primary refractory disease. And when we look at this column 1 study, which are the recruitments of patients from MD Anderson and Mayo Clinic, and from this large randomized controlled trials, Coral and Light 12, when the refractory search was done, and the patients who are primary refractory disease, progressive disease, or stable disease following 4 cycles of R-CHOP, or who had subjected to salvage chemotherapy, following which they had a progressive disease as a stable disease, or following transplant they relapsed within a year. All those refractory patients, when we analyzed the data was analyzed, the median survival of this patient, event-free survival, was only 6.3 months. And when we dissect the data, primary refractory disease, the median EFS was 7.1 months, and those who are refractory to second line or who are relapsed within less than 12 months of post autologous transplants, close to 6 months. When the response rates are compared to the event-free survival, CR rates, they had the median, the patients were achieved a complete remission. The event-free survival was close to 15 months. Whereas for partial response or non-responders, it is very dismal. And the patients who had undergone autologous transplant, so it is autologous transplant provides a survival advantage over the patients who are not undergoing a transplant. So the concern is the primary refractory disease. So what is primary refractory? Is the patients who are progressing during therapy, or who are less than CR, complete remission at the end of treatment, or having a stable disease, or having only partial remission at the end of the treatment. So the survival is somewhere around 20 to 30%. So what is the mechanism, or why are they refractory primarily to the chemotherapy? So this can be explained by the tumor cells, or the tumor microenvironment, or the patient's host themselves. The tumor is very heterogeneous in them, the tumor population, because there can be numerous clones pre-existing which can be very resistant to those chemotherapy. This is because they had acquired mutations in either the numerous mutations in the immune surveillance, or they have some epigenetic modifications, or some very resistant mutation like TP53 mutation, or certain oncogene like c-MYC mutation. All these can contribute to the tumor heterogeneity and the tumor being resistant to the chemotherapy. or there can be downregulation of the tumor infiltrating immune cells, or there can be upregulation of the inhibitory checkpoint molecules, or apoptosis can be inhibited by the cell adhesion mediated factors. All these can contribute to the disease being very resistant to chemotherapy, or the patient themselves may be having some single nucleotide polymorphism, making them resistant to chemotherapy. So what are the treatment options available for these patients? So we have MABs or CAR-T or bispecifics. So the second-line agents include this MAB, the tafasitamab, along with lenalidomide. So this was studied in patients who are previously exposed to single to 3-line therapies, and the overall response rate is somewhere close to 60%. And we look at the complete response rate, it's 40%. And the PFS is 11.6 months, and the overall survival is close to 33 months, and the duration of response is like 40 months. Whereas the primary refractory also had a very good response rate with this molecule. And the CAR-T, let us see the data of the CAR-T. So when we look at Azuma 7 study, the Axicell was compared with the salvage chemotherapy as the and the second line, the primary refractory patients. So the overall response rate and complete remission rate is way superior than the salvage chemo followed by autologous transplant, and the overall survival is not reached in these patients with Axicell. So Zuma 7 showed very clear difference in the survival and the response rate with CAR-T, rather than subjecting the patient to an autologous transplant following a salvage chemo. And Transform study with Lisa-cel again showed a very good response rate, a complete remission rate of 75%, and the PFS and OS is not reached with a median 18 months PFS was close to 58.2%, and the time to response is also within a month. And Lisa-cel from the pilot study was approved for patients who are not eligible for transplant. In those patients also the CR rate is close to 50%, and the PFS is 9 months, and the duration of response is like around a year. So what are the monoclonal antibodies are there in relapsed refractory? Is tafasitamab with lenalidomide, or loncastuximab tesirine, or pola-BR. So all these molecules had the overall response rate close to 50 to 60%, with the follow-up, median follow-up around 20 months for tafasitamab, and again for pola-BR it's around 27 months. And the PFS was 12.1 months with tafasitamab. With pola-BR it's 9.2 months. And duration of response, when we see, it is around 21 months with tafasitamab along with lenalidomide, and close to 10 months with loncastuximab. With pola-BR it's 12.4 months. And for the PFS, after the patients who had undergone CAR-T previously, the response rate is 36% with tafasitamab, and with pola-BR it's around 40%. And the PFS after CAR-T is like very dismal. It's less than 3 months. So this is Axicell, Tisacell, Lisa-cel we have discussed. What to be noted here is the signaling molecule, it's a co-stimulatory molecule, CD28 with Axicell, and Tisa and Lisa, it is 4-1BB. And this translates to their complications or side effects. The CRS more than
Also, I guess there is some technical difficulties with the.
Yes, something went wrong. Let us wait for 1 minute.
Okay, sir.
So I hope I'm visible and audible.
Yes, sir.
Yeah, you are visible. I think
Yeah.
you just go back one more slide.
Not able to.
Where you showed the selinexor part after you showed the loncastuzumab. Yeah, lonca plus tecidin plus then tafalen. That chart did you show? After that, one more slide. You go one back.
Just sorry for the interruption. So let me continue. So with this CAR T cell, axi-cell, TISA-cell, LISA-cell, all these are approved for the second as well as third line therapy. And the point to note here is that when we look at the complications, CRS and neurological adverse events are slightly more with axi-cell when compared to TISA and LISA-cell. This is because of the co-stimulatory molecule CD28 with axi-cell rather than 4-1BB with LISA and TISA-cell. Otherwise, the response rate, complete response, overall remission rate, and the PFS are almost similar in all. When you look at the third line options, we have again all the CAR-Ts are there along with POLA and BR. So for all these are approved for patients who are refractory or who are progressed following 2 lines of therapy. And the response rate is somewhere close to 40%, PFS of around 10 months with POLA BR. And the and all the CAR T cells, I just wanted to highlight the duration of response. Duration of response is very good, like it's around close to 10 to 11 months, and it's not reached with duration of remission and response is it's not reached with the LISA and TISA cell. And the complete remission also is quite encouraging with 40 to 50%. And next we have bispecifics in the line. We have epcoritamab or glofitamab, mosunetuzumab, odronextamab. So the overall response rate is like around 63% epcoritamab, and with glofitamab it is 52%, whereas with the other two molecules close to 30 or 35%. And the complete response rate is around 40% with epcoritamab and glofitamab, and the follow-up duration of 10.7 months or 12.6 months with epcoritamab and glofitamab respectively. And the duration of response remission is not reached with glofitamab, or it's around 10 months with epcoritamab. So with so many molecules now approved, like it was not the way when it was like way back, like 5 years or 4 or 5 years back. So in this 5 years showed tremendous improvements in the treatment of DLBCL. So we have monoclonal antibodies, bispecifics, and CAR T. So how to sequence therapy? So what is the paradox here is like we have so many molecules, but what to be placed in what sequence? So that is what is the confusion now. So this flowchart somehow clarifies that. So after first line, the patient is relapsed after first line of therapy. So those patients who are having a primary refractory disease or relapsed within a year of therapy are the very high risk candidates. So if they are CAR T eligible, they should be enrolled into CAR T therapy. Or if they are not eligible for CAR T, they should be treated with those antibody mediated therapies like tafasitamab or loconstuximab, or the patients can also be subjected to autologous transplant, but the response rate will be inferior in patients who are having a primary refractory disease. or if the patient is not a high risk. So the patient is relapsed following maybe a late relapse. In that case, we have to consider a autologous transplant following a salvage chemotherapy. Or the patient is not transplant eligible, then we can consider Lisacel as per this pilot trial. And if they relapsed following the CAR-T, then we have bispecifics. Or if the patient had relapsed after 2 or more lines of therapy and it's CAR-T eligible, you have to give CAR-T therapy for those patients. Or if the relapse following CAR-T, then comes the bispecifics. Or due to some logistic issues, or CAR-T is not available, or the patient is not CAR-T eligible, then bispecifics can be given after 2 or more lines of therapy, rather than subjecting the patient to salvage chemotherapy. So these are the numerous bispecific molecules which are available: epcoritamab and all those we have discussed, glofitamab. So when we compare bispecifics versus CAR-T, so CAR-T requires the patient's T cells to be harvested, and it involves viral transduction, and this logistics and expansion and then infusing to the patient. This logistics takes around around 3 to 4 weeks, or maybe 6 weeks. So this logistical issues are there. Whereas when we look at the data of CAR-T over bispecifics, the CAR-T we have the long follow-up data. So 5 years follow-up is available, and the potential for cure is there in 1/3 of the patients with CAR-T. So this cannot be, we cannot just forego with CAR-T. And the point to note is CAR-Ts, they contain themselves, they contain a co-stimulatory molecules. They do not depend on the patient's T cell proliferation, unlike this bispecific, which does not have a co-stimulatory molecule. So it depends on the innate immunity of the patient to form an immune synapse, and then for its action. But one concern can be following CAR-T therapy. If the patient relapses, the patient can have antigen loss or antigen escape. So the patient can even develop relapse following CAR-T also. There can be resistance also following CAR-T. So can bispecifics be used instead of CAR-T in the second line? So eventually patient 2/3 are going to relapse after CAR-T. The outcome of these patients are going to be very dismal, and the overall survival median is around only less than 6 months. So that one point can be considered for using bispecifics over CAR-T in the second line. And the other thing is the logistics and time consuming process, whereas bispecifics, they are available off the shelf, so they can be used readily. Yeah, that is the advantage of using bispecific. They're readily available. And but the main concern is there is no long-term data with this molecule. So that is one drawback. There is also theoretical concern about T cell exhaustion following the bispecific antibodies. Later, if the patient relapse, the T cell might be exhausted, or the patient may not be able to apheres and get a CAR-T product. That is one theoretical concern. But there are numerous studies which are refuting this also. So this is what we discussed in the previous slide: CAR-T versus bispecific. So there is a long-term follow-up data with CAR-T, and only single infusion is needed, whereas with bispecific, we do not have long-term data. Repeated infusions may be required, like an immune boost, and bridging therapy is needed in CAR-T. And the only concern is the duration or logistics of producing and CAR-T is the only issue with that. Whereas bispecific is readily available, we can use it as a treatment option. So we'll see in detail about glofitamab. So this is a bispecific, having a 2:1 configuration of CD20 and CD3 binding domain. So this molecule binds to two CD20 molecules and the malignant B cell, and it also binds to the T cell with the CD3 binding domain. So with that, it forms an immune synapse and makes the T cell attack your malignant B cells. So data phase 2 regarding the safety and efficacy of this glofitamab as a monotherapy in patients with relapsed refractory DLBCLs, more than 2 lines of therapy. 155 patients were enrolled, And all these patients should have received intravenous obinutuzumab was given for a week before initiation of glofitamab. This is to prevent the cytokine release syndrome, because this obinutuzumab, it will go and attack the tissue-related B cells, and thus the risk of CRS is reduced, following which glofitamab is infused. And glofitamab is continued for 12 cycles or until progression or till unacceptable toxicities occurred. The dosage is given in a stepped up manner. So the primary efficacy endpoint was complete response. So look, the complete response, the median follow-up duration 12.6 months, it's around 40%. And when we combine both partial and complete response, close to 50%. There are no very severe adverse events with no grade 5 adverse events. With grade 3 or 4, anemia and thrombocytopenia are quite manageable. And neutropenia, 1/3 of the patients, they did have neutropenia. When we look at the data of phase 3 trial of this glofitamab in autologous transplant ineligible patients with relapsed refractory DLBCL, so the total of 274 patients were enrolled who had relapsed refractory DLBCL NOS, who are not eligible for autologous transplant. So one arm was given glofitamab GemOx. So other arm was given rituximab GemOx. So gemcitabine oxaliplatin. It was continued for 12 cycles. So first 8 cycles. It was a 21-day cycle, and glofitamab dose was stepped up. The first cycle, 2.5 mg was given on day 8, and 10 mg was given on day 15. And from the next cycles, 30 mg was administered. So it was a 2:1 randomization. So this is a consort diagram showing the enrollment of patients in both the arms. When you look at the primary endpoint, there is overall survival. Glofitamab arm showed a very good response, and the median follow-up duration of 11.3 months. The overall response was higher with this glofitamab molecule. When the median overall follow-up of 20.7 months, also the hazard ratio was less than 1, and the glofitamab arm showed a very good overall survival when compared to those who did not have this glofitamab. And the median PFS was 13.8 months with the glofitamab GemOx. And the duration of response is also superior than the patients who did not have glofitamab. So this is a forest plot, shows despite the number of therapies the patient who had received previously, or the patient was previously exposed to CAR-T or not, or in spite of the refractory status, so irrespective of whatever risk the patient was in, or the bulky disease nature or the center of cell origin, all those favored a glofitamab arm only. The safety concerns, there are grade 5 fatal events were almost comparable with both arms, and other adverse events are also comparable, though glofitamab arm had slightly more toxicities than this arm had only GemOx. So commonest adverse events were thrombocytopenia, cytopenias, and CRS, and peripheral neuropathy, and mild transaminitis and diarrhea. All those were comparable both arms, and serious adverse events were slightly higher in glofitamab arm than the arm which did not have glofitamab. And all the CRS were only up to grade 3 and were manageable, and ICANS was not very severe, and febrile neutropenia is also comparable with both arms. So the conclusion of this trial is the median overall survival is 25.5 months with glofitamab arm compared to 12.9 months with R-GemOx, and glofitamab had better PFS and CR rates, and this was very tolerable, and the adverse events were expected of this, and the CRS were also only low grade, those were manageable. What is the real world data of this glofitamab is? So this article published in Blood Advances, this is a retrospective multi-center multinational study in German, Australia, and Swiss. 70 patients with relapsed refractory DLBCL were treated with glofitamab as a part of the compassionate use patient program. All the median number of prior treatment lines was 4, with almost 1/3, 2/3 of the patients, they had prior CAR T therapy and they were refractory to their last treatment. The overall response rate was 47%, with 27% achieving complete response and 20 had partial response. The overall median survival was 5.7 months and median PFS was 3.6 months. So approximately 19% were in CR 6 months after the initiation of glofitamab, and they had durable responses. The only one indicator of having a poor survival or inferior outcome was elevated LDH. The CRS and ICANS all had only grade 1 or 2, and 3 and 4 were relatively less. CRS were present in 40% of the patients, ICANS in 10%. Grade 3 was only 1%. Infections were there in 1/3 of the patients, and the patients who had pre-treated with bendamustine within the past 6 months prior to the initiation of glofitamab, they had significantly reduced PFS. This is because bendamustine that impairs the T cell function fitness and thus the efficacy of the glofitamab, similar to that of a CAR T cell therapy. So this is the PFS and OS comparison with that of the multiple parameters. So those bold highlighted are those who had significant, and then bendamustine in the past 6 months they had poor PFS, and CAR T naive patients, they in this CAR T naive patients actually they had inferior PFS and inferior OS, and rather than the patients who had exposed to CAR T. And the bulky disease that had the patients who had bulky disease had inferior PFS than patients who did not have. But one thing which is consistent, the multivariate analysis also is the LDH. Only parameter is LDH, elevated LDH. So this is what we have discussed in this slide, in the table. And one point to note here is in this study, they had shown the transformed DLBCL, they had better results with glofitamab than patients who had a primary DLBCL NOS or a high-grade B-cell lymphoma. But this data was not, this could not be extrapolated, and this only very few patients were there, so we couldn't extrapolate to a multitude level. So is there any resistance with glofitamab? So the patients who had not responded very well to glofitamab when the molecular studies was done, they showed a high level of c-MYC expression was there in them, and the markers of proliferation, immune escape were predominant in those patients. And responders, they did have lower expression of PD-1, or the patients had intratumoral CD8 signature genes were present in those patients who had responded. So this indicates that baseline infiltration with the less exhausted T cell population, and there is a complex interplay between the tumor cell and the T cells host factors. So to overcome glofitamab resistance, there are studies coming up with combining a PD-L1 inhibitor, atezolizumab, with glofitamab, and also targeting other checkpoints like CTLA4 and LAG3, and also combining glofitamab with lenalidomide, which is known to be a very good immune modulator and improving the T cell fitness. Sir, any data on glofitamab to be used as a frontline therapy? So this published recently is glofitamab plus Orchop or Pola-R-CHP is in high-risk patients less than 65 years in patients who are having a high-grade B-cell lymphoma. It's a multi-center phase 1-2 trial of glofitamab in combination with Orchop or Pola-R-CHP. Patients were young, between 18 to 65 with high-risk DLBCL for at least one high-risk feature, IPA more than 3 or NCCN IPA more than 4 or proven double hit status. So for the first cycle alone, they had allowed first cycle of Orchop to prevent the treatment, minimize the treatment delay, and 5 cycles of glofitamab was given with in the stepped up manner, and the first cycle and the second cycle or the next 4 cycles 30 mg start dose was given. There's a IV infusion over 4 hours. Later it was reduced to 2 hours. So in combination with Orchop or Pola-R-CHP, this was followed by 2 cycles of glofitamab consolidation. The primary endpoints is safety, relative dose intensity, and rates of treatment discontinuation. So there are 47 patients in the both arms randomized. Of these treated patients, 89% had a de novo DLBCL high-grade B-cell lymphoma, 11% had transformed indolent lymphoma. Grade 3 adverse events were present in 40% in the glofitamab arm, or whereas 50% in the polarchip arm. And febrile neutropenia were also were actually more in the polarchip arm. And CRS was almost equal in both. And grade 2 CRS was one episode of grade 2 CRS was in arm A after 10 mg of glofitamab. There were no grade 3 or 4 events. And the rate of relative dose intensity was more than 90% for cyclophosphamide, was 93 with all the molecules. 41 patients had at least one efficacy assessment with best overall response rate of 100%. Of the 25% who had end of induction assessment, 76% had achieved complete remission, 20% had partial response, 5% had progressive disease. So only one patient had progressive disease. So a median follow-up of 3.7 months, the estimated PFS was 91%. So this was a poster presented at ASH 24. So Sky Globe, this is a randomized phase 3 trial of glofitamab polarchip versus polarchip in untreated large B-cell lymphoma patients. So eligibility is untreated CD20 positive large B-cell lymphoma, age 18 to 80 years, more than one bidimension measurable lesion, more than 1.5 centimeter is longest dimension, type A score of 2 to 5, and good performance status. 1,130 patients were randomized to 1:1, and the treatment will be administered over 8 cycles of 21 days each. And so it's almost like the step-up dose which I've discussed in the previous phase 1 or 2 trials. So the primary endpoint will be PFS, and the secondary endpoint is objective response and complete response, and overall DFS, duration of response. The results are yet to be out. So to summarize, the approximately 30 to 40% DLBC and the relapse following the frontline chemoimmunotherapy. The chemosensitive disease, the patient having a late relapse, they have a chemosensitive disease. They should undergo a salvage chemotherapy followed by platinum-based, followed by a autologous transplant. This is the standard of care. So the patient who had a primary refractory disease, or who had a stable disease following the first line treatment, or who had relapsed within a year of the frontline chemotherapy, we have to consider CAR T therapy in them, because their the tumor cells or this tumor microenvironment mutations making them the chemo resistant disease. And the CAR T cell has a very good durable response. The only issue with it is the CRS and ICANS are all manageable, but logistic issue has to be considered. So there are numerous molecules in the pipe which have approved, and numerous are coming up. Combination therapies are in the pipeline. So we have to choose which one to be placed in the front line, even as the second line. So like either monoclonal antibodies like tafasitamab or Pola BR, doncastuximab, they are also alternate to salvage chemo or followed by autologous transplant in patients who are not eligible for autologous transplant or CAR T. And CAR T relapses, the response are very poor, and bispecific is the only therapeutic option following a post CAR T relapse. But there are good data which shows that bispecific can be used as a second line therapy instead of CAR T, or even in the first line also untreated patients. The data is coming up. So these molecules, all these bispecific, are going to make difference in the next decade. So thank you all for this wonderful opportunity.
Dr. Ramesh, wonderful talk. Fantastic. And I now request our discussants to please put the hand raised sign so that we can start our question session with Dr. Ramesh. So in the meanwhile, when the question starts pouring to you, I have a question for you. Those patients who are elderly, say for example 70, 75 years of age, elderly DLBCL, transplant not eligible, refractory to R-CHOP, you go for polar BR, refractory to polar BR. And now, what would be your next line of therapy? Should we go for bispecifics in such cases or to go for CAR T cell therapy? Elderly patients, 70, 75 years of age.
70, even the chronological age should not be a cutoff for not subjecting the patient for a CAR T. So unlike autologous transplant, or the eligibility differs here. So if that shouldn't restrict the patient from using a CAR T. If cost is not a constraint, CAR T can be still an option for them. Or bispecifics, they're readily available. So I think the bispecific can also be a very good choice to be used as a second line therapy instead of CAR T.
So before CAR T, should we need to debulk the patient before going for CAR T? And if you're debulking the patient, what would be the best regimen would you like to choose before going for CAR T?
So before going to the CAR T, the debulking is actually mandatory, and we have to give lymphodepletion has to be done with fludarabine, or we have to give.
Not the CAR T lymphodepletion. Before going for the CAR T cell products to be available to you, okay, before the CAR T therapy, any debulking of the tumor you need to do before the CAR T cell?
So to mitigate the side effects of CRS and ICANS, I think we have to do the debulking with other agents before subjecting the patient for CAR T.
So you have a tumor bulk of, for example, 10 centimeter tumor mass, and you're projecting the patient to CAR T cell therapy. So any regimen will give Chimox or anything before proceeding to CAR T, or directly straight away to CAR T?
We can give Gemox and then take up the patient for CAR T to reduce the tumor burden, and then take up for CAR T.
Okay. Any data regarding the transplant non-eligible patient directly switching over to Glofit GMOX, because you already saw the STAR Glow studies. So directly, can we go for Glofit GMOX and then followed by CAR T in such patients?
So the data is encouraging with glofitamab. So that can be used in the second line also. The Sky Glow and Star Glow shows very good response rates, comparable. But the thing is, like, whether will it be durable? So that is one concern. And following subjecting the patient to glofitamab based therapy, if the patient has to be taken up for CAR T, there is some risk of T cell exhaustion, that the T cells may not be collected very well for the CAR T. That is one concern. But there are studies which show that, like, that is not a major problem following even given glofitamab also.
So we can go for Glofit GMOX followed by CAR T.
Yeah, yes.
That can be the best
Yes. Yes.
for non-eligible candidates. Second question is regarding the patients who are young fit patients and relapsing within the first year of therapy, or maybe refractory to the R-CHOP therapy. So would you like to go for autologous stem cell transplant or CAR T cell therapy directly?
So the Zuma 7 trial shows a very clear benefit of CAR T over autologous transplant in such patients who are having a primary refractory disease. So I'll subject the patient to CAR T rather than exposing them to autologous transplant, because they'll be having a chemo-resistant disease per se.
And any role of CAR T cell therapy in extramedullary DLBCL or affecting the CNS or any other sites?
CNS, I'm not very sure, so, like, whether the CAR T will be much beneficial in them.
So CNS CAR T cell doesn't help. Any other thing, any other sites where the CAR T cell is going to help in DLBCL apart from CNS involvement?
Other
Because
extramedullary, you mean?
extramedullary, yes. Does it help for testicular DLBCL?
I'm not sure.
Okay. So has anybody questions? Any questions for Dr. Ramesh? So there is one question which is related to one question related to the cost of glofitamab. Any idea regarding the cost of glofitamab?
No idea. I've not used.
Yeah. the third question is related to the glofitamab side effects. How would you go for the CRS management in the patients with glofitamab? Whether this CRS management can be undertaken on OPD basis?
The CRS, as per the data, is very it's like not very high grades, like grade 1 or 2. So this should be easily manageable with steroids, or they can be can be managed on OPD basis also.
Can you manage on OPD basis? Okay. So Dr. Vinayak Chikodi, you have any question? Dr. Vinayak?
Am I audible?
Yes, yes, sir. Please go ahead.
Yeah. How common are CRS and neurotoxicity with bispecifics? CRS and neurotoxicity with bispecifics.
So, as per the data, like it's around, it's mostly around within grade 3, sir. Like grade 4 and it's not very common. Grade 1 or 2 is more common with them. But 3 and 4 is very less.
So they can be used quite safely then.
Yeah, it's quite safe.
Yes, yes, yes. Thank you so much, sir.
Thank you, sir.
Thank you, sir. Thank you.
Thank you, sir.
Thank you, Dr. Khurana also.
Thank you so much, sir. And Dr.
Thank
Ramesh, you spoke about the LDH level of more than 400, which is a bad prognostic factor, basically. So, would you like to try to avoid glofitamab in such cases? And if yes, then what would be your regimen of choice? Because DLBCL refractory, the ideal regimen now, what is coming up is Glofit GMOX, and then followed by CAR T cell therapy in primary refractory DLBCL. But when you see the LDH levels are always 1400, 1500, almost more than 400. So would you like to try to avoid Glofit and give only R-GMOX to such patients or any other regimens before proceeding to CAR T?
So as of now, the better regimen will be for a primary refractory disease. It will be for tumor debulking. It should be Glofit GMOX only. Or despite we do not have very many other choices to have a very good tumor debulking. Irrespective of LDH, I think though very high LDH is going to be doing not very good, but still we do not have very great drug. Comparing the glofitamab as of now. So glofitamab combined with the GemOx, or that will be a better option. Or there is like glofit polo or chip, which is the data is there for a primary frontline setting. We can use it that also glofit along with pola or chip.
Thank you. There is one question related to 60 years male who is a refractory DLBCL, refractory to R-CHOP. They have tried with refractory to Pola R-CHP. They have tried with Pola BR, refractory 2 cycles given. Should we go for now Glofit GMOX in such patients? Because you already said bendamustine patient should not be as inferior outcome. The patient has already been given bendamustine in last 6 months. So Pola R-CHP followed by Pola BR, and now whether the patient is eligible to get Glofit GMOX.
So bendamustine, if it is used within the 6 months, the response rate is going to be poor. The same case with CAR T also. The CAR T, the yield of cells will be less. So in this case, the disease being very refractory, we can try other monoclonal antibodies in these patients. Tafasitamab, those can be tried in these patients.
Fine. Thank you. So, yeah, one more question has come. Can we go for, is there any role of lead maintenance post CAR T? Lead maintenance post CAR T? Any role of that? Or post autologous stem cell transplant? Any role of lead maintenance in high risk DLBCL post CAR T as well as post autologous stem cell transplant? And if yes, what is the role of lead and duration of lead?
So there is no added benefit, OS or PFS benefit of adding lenalidomide with after CAR T cell therapy, or even after autologous transplant also. So,
all right. Fine. Yeah. Anybody has any other question? Well, so thank you, Dr. Ramesh. A fantastic talk. You have covered almost everything. And a fantastic discussion with you. Thank you so much. And that comes to the end of our three guest speakers. Hats off to all the three guest speakers. Wonderful lectures given by all the three. Fantastic. And I also thank all our discussants and the audience to participate in this beautiful webinar of these three lectures, starting from 10 a.m. to ending up at 2 p.m. Long way. Thank you so much. And now meet you next week, Saturday, Sunday. Thanks a lot.
Thank you, Karuna sir. Thank you, Anvachi. Thanks, Ruchi.
Thank you. Thanks all of you.
Thank all the discussants. Thank you.